Right. Okay. So, welcome to the this conference, Injured Brains of Medical Minds, Views from Within. I'm Narinder Kapur. I'm attached to University College London, and you will see there on the left-hand side, you see the front cover of the book, which will be coming out next Tuesday, I think November the 19th. Uh, and this is the book will be print copy will be £119, but there's a link in the chat box to the PDF flyer, which means you can get a 30% discount. The Kindle version is around £80, and if you attach a university and that university subscribes to Oxford, um, the Oxford scheme, then you can Oxford scholarship scheme, you can access that the book free. Now let's see, can I just turn this? I can't really move this. The book when's coming out, it will be the second edition of the 1997 book, and the new book will be entirely new. There'll be new chapters, new authors, and everything. It'll be quite different from the 1997 book. Um, the um, uh, um, uh, the 1997 book did have some excellent reviews. Louis Kaplan in America said, Injured Brains of Medical Minds is a wonderful book. It should be mandatory reading for all physicians and health professionals who care for patients with neurological diseases. All physicians would find it a good read and would profit from its multiple messages. I highly recommend Injured Brains of Medical Minds as a must read and reread. And then Dr. Simon Feminger, attached to Imperial, said, I found some of the accounts inspiring. The book is very well presented and is highly recommended. And then in the BMJ, it said, the work is beautifully presented and the occasional illustrations pertinent throughout. What is impressive is the personal narrative and the great courage shown by the authors. Now, in the last few years, there's been quite an interest in patients' perspectives on brain injury, so-called experts with experience. And so there have been a series of books like in this After Brain Injury Survivor Stories, where patients have talked about what it's like to have a brain injury and a brain illness. Rootledge have published that. And the Neurology Journal based in America has this Physicians as Patient series, and some of those relate to doctors who've had a neurological condition and described what it was like. And there have been videos on YouTube, webinars by doctors who've had a neurological condition, and there's just a selection of those, and they've been quite informative. In the UK, we've had what's called the Practitioner Health Service, which is a service for doctors, dentists, and other healthcare staff who need help with a medical condition. It could be neurological or it could be some other condition. And this Practitioner Health Service has proved to be very popular and very helpful. And from an academic point of view, doctors like this group in Australia have looked at the issue of doctors treating doctors and what's involved. And in this paper, they concluded doctors can find treating doctor patients anxiety provoking and challenging. The sources of this discomfort are multifaceted, and more empirical research is needed to better understand and address the complex relationship between treating doctor and doctor patient. And the same group published another paper where they concluded the professional socialization of doctors with this emphasis on collegiality and respect plays a significant role in the dynamics of the therapeutic relationship when a doctor treats a doctor patient. Current guidelines make little reference to these dynamics with the oversimplified keep it normal recommendations. Treating doctors need evidence-informed training to navigate these challenges and ensure that they can effectively deliver quality care to their doctor patients. Now, all the book royalties from Injured Brains of Medical Minds book that's coming out shortly, they'll go to 2 charity funds I've set up to run award schemes that help patient care and staff well-being in the UK and in developing countries. And these award schemes are in memory of Nurse Amin Abdullah and Dr. Karen Wu. And the book is also dedicated to Amin and to Karen. Just to tell you a little bit about Amin and Karen, Amin Abdullah was of Indian origin. He grew up in an orphanage in Malaysia. He fulfilled his dream of becoming a nurse in the NHS, and during his training, he won an award from the hospital that later employed him. He was a whistleblower and had raised patient safety concerns. On February the 9th, 2016, not long after he qualified, and a few weeks after going through a kangaroo court dismissal procedure, he burnt himself to death outside Kensington Palace. Subsequent inquiries following his death have affirmed the critical importance of principles of fairness in NHS HR procedures, and I've called these PIE, plurality, independence, and expertise in panels. We've yet to see the UK Department of Health have these as requirements for NHS trusts, and I hope that happens soon. I've set up 2 award schemes in his name, one at the Royal College of Nursing Foundation and the other at Southampton General Hospital, where I once worked. And then Karen Wu. Karen was a UCL medical graduate who was killed whilst on a medical aid mission in Afghanistan in August 2010. She was killed along with 9 other aid workers. I've set up 2 schemes in her name, an award scheme at the UCL Medical School to give an award to medical students who do excellent work in developing countries, and a fund at the Afghan Healthcare Association to help provide healthcare resources in Afghanistan. You can find out some more resources on my website, betternhs.com. I'd just like to thank my co-editors, Von Bell, attached to UCL, Daniel Friedland, attached to Imperial College, and Stephen Kemp, attached to Leeds Beckett University, for their help in putting together the book and the conference. I'd like to also thank my colleagues here who've helped with the conference and the book: Banika Ahuja, King Chihao, Malini Marasingham, Veronica Bradley, Joanna Friedland, and Shahina Begum. Shahina is my current excellent psychology assistant, and she'll be available for work in the next few months. If any of you have a vacancy coming up, please let me know. Now, this is the program for the conference, and as I said, the link for this program is in the chat box. During the lunch interval from about 1 o'clock to 2 o'clock, there'll be a 33 slides display of books and podcasts, most of which are reviewed in the book. We'll also cover a few books about doctors as patients that for various reasons we could not review in the book. Each book, set of podcasts, will come up for about 15 seconds. The 33 slides display will be repeated 4 times. Feel free to take a picture of those slides that you may be interested in. And each of the talks will last for 30 minutes, and there'll be 10 minutes for questions. You type your questions in the Q&A box. Since we probably will not have time to deal with all questions, I will summarize some questions into a single question or pick ones that overlap with others. You can also use chat box to make any comments or suggestions. And in the chat box, there's also a link to a feedback form that you can complete after the conference. The conference will be recorded and will be later available on the Institute of Neurology YouTube website. And those of you who are interested in some neuropsychology resources, there are some more on my website, neuropsychologyresources.com. So that's my introduction, and I'll just now hand over to the first speaker, who is Professor Cyrus Kuipers. Cyrus Kuipers is a professor of rheumatology at the University of Southampton and a consultant rheumatologist at Southampton University Hospital's NHS Trust. He directed the MRC Lifecourse Epidemiology Unit at the university from 2003 to 2023, retiring as Emeritus thereafter. He has spent 40 years studying the etiology, prevention, and treatment of osteoporosis and other musculoskeletal disorders. He was awarded an OBE in 2015. So over to you, Cyrus, for your presentation.
Thank you very much, Narinder, and good day, ladies and gentlemen. It's perhaps fitting that you have a colleague from Southampton days, and one that was there at the time that you were there, at this wonderful Injured Brains of Medical Minds conference and subsequent co-authoring of the chapters within your book. My name is Cyrus Cooper. I'm a professor of rheumatology and director of the MRC Lifecourse Epidemiology unit at the University of Southampton, and professor of musculoskeletal science at the University of Oxford until my retirement from the latter post last year as a consequence of my illness. I was born, by way of introduction, in 1957 in Dar es Salaam, Tanganyika. So I had my first 11 years by the beach, only about 4 to 5 hours of schooling each day. And I thought that life was really extremely good. Unfortunately, in 1968, we moved to North London, to Hendon in NW4, and I went to school, thankfully, at Christ's College, Finchley, between 1968 and 1974. So here is, on the top left, my parents, who were both born in India and moved to East Africa, as I mentioned. And subsequently, we moved to the United Kingdom, as I said, in 1968. I went to grammar school, Christ's College, Finchley, from 68 to 74. Then Gonville and Caius College, Cambridge, in 74 to 77, and St Bartholomew's Hospital, London, 77 to 80. I married my future wife in 1984, but met her in 1981. And soon after that, we moved to Southampton. And that's really where my postgraduate working lifetime has been for the last 40 years. I sadly lost Margie due to pulmonary hypertension in 2021, and had the good fortune to have 2 wonderful sons, Philip and Charlie, who are now in their 30s and are such a great help to me at this period of my life now. So when I first came to Southampton, I worked at a newly formed medical school, which had started in 1970, and we arrived 10 years later. And that has changed substantially over the period since then, so that the site is now completely covered in clinical services. I myself undertook my my postgraduate training at the MRC Lifecourse Epidemiology unit, which at the time was called the Environmental Epidemiology unit. My clinical training was MRCP in 1983. My research training started with my DM thesis on the epidemiology of hip fracture, and osteoporosis is the subject that I've studied ever since that time. I became an MRC research fellow for 2 years after that, and then moved to a senior registrar job in rheumatology in Bristol, and won an MRC traveling fellowship to the Mayo Clinic between 1990 and 91. I returned to Southampton as a senior lecturer and subsequently a professor in 1992, and have remained there for my research programs ever since. The unit that I used to research in, I subsequently took over. The founding director was Professor Donald Aitchison, the chief medical officer after his time in Southampton. He was followed by Professor David Barker, and then 3 periods of tenure between 2003 and 23 as the director of the unit then. And I was delighted to be able to appoint, in one of my first actions after recovering from my brain biopsy, my successor, Nicholas Harvey, who took over last year and was someone who trained in the unit under my directorship and has now taken on the mantle. Of course, I could talk to you about osteoporosis for a good long period, but that's not the purpose of today. If you want to learn about what we've done in osteoporosis, one of the easiest places you can have a quick look is to one of the Tim Spector Zoe podcasts on osteoporosis that he and I did just a few months ago after I'd been diagnosed and treated for my brain biopsy. So it's not a subject that is so challenging that it needs the full faculties of one's cognitive control. All I do from the professional time of my life is to thank the former students who I now learn from. And it's been a wonderful period of time. I thank my family also, Margie, who, as I told you, passed away, but who was here at Buckingham Palace with me and the two boys on a great day. The people that I've met through osteoporosis, and here is the receipt of the Duchess of Cornwall Award by Her Royal Highness, who, of course, more recently has risen to even greater heights as Her Majesty, the Queen. And of course, my close colleagues over many years, and the person who's helped me most with this particular contribution, Jill Strange, who was the unit administrator for me for a period of over 25 years. It was fun in 2020 to provide Her Royal Highness with a PhD in Southampton. She has been a steady supporter of osteoporosis research and care, and that has just been one of the many fun times we've had throughout the research and clinical practice together. Now let's turn to the matter in hand, which is called Ode to Charlie, and which is really a series of reflections on a left parietal glioblastoma. At some point during late 2022, I started to notice a peculiarity in my speech and a little difficulty in managing my emails. I was slow at texting. I had a minor driving accident when I went too close to the side gate of my house, and I thought, my wife only having passed away from pulmonary hypertension, as I mentioned, the November previously in 2021, that I had hardly had any time to grieve. I wondered, given that my son was a psychiatrist, Charlie, my younger son, whether I needed to spend a little time dwelling on my loss, and pondered whether a prolonged stay in Ireland, my wife's hometown, and a place where we had a second home, would be good for me. This would also give me time to think about the family, my boys, and the best way forward. Nevertheless, I thought that there were some strange features about my state. One of these was that I was starting to become aware that I was dropping things. I was always a little on the clumsy side, but this was becoming more frequent. First, I dropped a glass of rather ordinary wine in my son's new home in London. Second, I dropped a more expensive glass of wine in a lovely restaurant called Cheeky's in the West End, where we went after Charlie's graduation ceremony in King's College, London, in September of that year. And we were also celebrating the fact that he had been awarded 2 major research prizes in his MSc psychology exam. But as you will see later, my pièce de résistance in terms of dropping wine was when I reached a conference in Geneva. That was a week later. At the entrance to the airport lounge, my bag was searched, and it was a trying experience at the best of times, given that I'd not travelled over the COVID period and was not practiced at travelling with deodorant, shaving foam, computers, and other paraphernalia in the Terminal 5 lounge. Later on, in the restaurant area of the lounge, my problem became apparent. My sleeve was drenched in blood that had dried from when I had inadvertently injured myself in the baggage area. A very nice lady made it all better, and I went on my way. The pièce de résistance, as I say, was at the hotel in Geneva. In one frenzied moment, I managed to empty 3 large glasses of a fine red wine, Sassicaia, for those of you that might be interested, because I was concentrating way too much on sarcopenia, that's muscle loss, compared with the wine. At this point, enough was enough for my 2 great colleagues in osteoporosis research, Jean-Yves Regenster and René Ritzelet, and they took me up to their room, sat me down, and suggested that I needed to have a CT scan there and then in Geneva. I said that I was in a state because I was still grieving the loss of my wife. They said that was rubbish. The compromise position was that I would return to London and immediately visit my own hospital in Southampton. Over the period of that trip, I was clearly more clumsy. I had cut myself inadvertently on the baggage check-in and also in the airport lounge. My surroundings in the Geneva hotel were vague, and I started to bump into things and drop items. So I resolved that I would arrange a CT scan immediately. Soon after arriving home from Geneva, my son arrived. He was keen to examine me on the living room couch, and he proceeded initially with a peripheral neurological examination. To both his and my surprise, my feeling in all modalities was completely intact in my left side, but in my right arm and leg, there was absolutely zero sensation for pinprick and vibration, though I had some light touch and some clear pain because he was pressing quite hard on the both right and left arms. The sensation difference between the 2 sides was so profound that the left side of my body remained in abject pain for some seconds after his pinprick. At this point, it was becoming apparent that my language had progressively worsened, and it was taking me around half to 3/4 of an hour to type a single email with many corrections, many miscalculations of words, and an inability to spell or even construct language. Yet the clarity of my thought was almost completely perfect, and I'd been able to give answers to questions in the Geneva meeting without any difficulty about the sarcopenia topic. The clarity, Charlie, of course, as a psychiatrist, proceeded to inform me that this was a central nervous system disorder and likely to be non-vascular. We then dwelt on the nature of grief and how things went before deciding that we would have a cup of coffee and go to the casualty department at University Hospital, Southampton. The next phase of this story is really an ode to the wonderful nature of care that I received at the hospital where I've served for over 40 years since 1981. Over the last several years, and indeed perhaps over the entire 40 years of my professional life, it has been a fairly regular occurrence for the NHS to be engulfed in one or other forms of crisis. These are usually crises of finance, but they're also crises of confidence, of staffing, of intellect, and of leadership. It must be said, however, that on this particular occasion, I could see nothing of crisis, only of beauty. From the minute I received hospital inpatient care until the day I was discharged home some 4 days later, I was surrounded by care that was excellent, by staff who were wonderful, by support structures that were motivated and efficient,
Cyrus, so do you want to move slides, Cyrus? Do you want to move your slide?
Pardon?
Move your slide forward.
I was going to finish the narrative and then go on talking. But if you'd like me to, I'll happily continue thereafter. So I had manifestations that included unsteadiness and gait instability, right arm and leg clumsiness, inattention to the right, knocking of glasses of wine increasingly frequent and expensive, and inability to text and write. I subsequently had a CT scan, which showed that I had left parietal brain tumor, and this shows a gadolinium-enhanced MRI scan many months after I'd started treatment, which revealed the glioma. The biopsy was on the 12th of September 2022, and it turned out histologically and pathologically to be a WHO G4 IDH wild type MGMT 50 to 100% positive tumor. My treatment status included 10 fractions of radiotherapy before my admission to hospital, for a second visit when I took a strong turn for the worse. And 30 gigabytes were given in 10 fractions with Avastin at that time. I completed a final cycle of lomustine and temozolomide on the 26th of June 2023. And for the last year, pretty well, I've been off all glucocorticoids. I've had 4 weekly Avastin between then and the present time, and have remained stable over that period. My functional status and disability were principally at this time walking, the absence of driving, which really hindered my quality of life, my short-term memory, so that while I could remember what was at numbers 1 to 10 in the pop charts in 1974, I could hardly remember what had happened for the last couple of years. Inability to focus on a single task, which was even more pronounced than it had been before that time. Difficulty with sleep and household tasks, cooking and cleaning. My independence and living, I am still able, 2 years following diagnosis of this inoperable parietal tumor, to live at home. I manage the stairs. I have huge help from family and friends, and indeed for this talk was helped enormously by my colleague Jill Strange, who I showed you earlier on in the slides. Support from secondary and primary care has been essential. I've planned finances for the boys, but the home circumstances, renewed the home, managed the garden, and I look after my 4-year-old Labrador. So, to summarize glioblastoma multiforme, it's the most common malignant primary brain tumor. Its clinical presentation is protean. I've given you what I experienced. Its treatment includes surgical excision where possible, radiotherapy, chemotherapy, and individualized immunotherapy. The tumor size at diagnosis is around 4 centimeters, which was exactly the size when I was admitted initially. It's based, diagnosis is based on histology, cytology, and histochemistry. If intraoperative removal is impossible, fine needle aspiration can be attempted. Of the now wider range of treatment options, because progress has been made in the last 3 or 4 years. I was unable to tolerate surgery. This tumor was too large and deep and would have damaged brain structures too much if I'd had that. I had an aggressive course of radiotherapy, particularly when I took a downhill turn. And at that time, it was thought that I would be going straight from the admissions ward and then the neuro-oncology ward at the General to terminal care at Countess Mountbatten. When I got home, and had recovered because I had started Avastin together with high-dose corticosteroids, I completed the radiotherapy course and had temozolomide for 6 courses of chemotherapy, together with the Avastin on a monthly basis, which I've continued since that time until the present. So if I give you some tips for patients with GBM, maintain positive attitude. That has been absolutely essential. I've been able to continue some degree of working, although I've tapered off. I'm now age 67, and I've tapered off in the last year or 2, but still I'm able to enjoy sojourns such as this. Trust your caregivers. I could not have been under better neurosurgical care than Paul Grundy, who took care of me right through my brain biopsy and then passed me to Dr. Ching, the neuro-oncologist in the department. I trusted the caregivers, all of whom have been important to my management of the condition, and try and use family and friends as much as possible. Top tips for doctors and nurses: the acute phase is not the end of the journey, as I thought it would be, but have found out that it is not, even for something like an inoperable brain tumor. All ancillary support and social care are critical. Liaise closely with the nurse-led teams and allow lots of time for questioning and re-questioning, because people are only too happy to help you if they feel that you are up to the answers that you would give. So my acknowledgements to Dr. Zheng Qing and the neuro-oncology team at UHS, and of course my thanks to Narinder for putting on this fantastic program that I shall listen to with great interest throughout the day, and for giving me the opportunity of my contribution to be described to you this morning. Charlie, Philip, Margie, and all my family and friends, and as I said, my colleague, Gillian Strange. Thank you very much indeed, and I will stop sharing there.
Okay, right. We've got one question here. Yeah, one question here. So thank you for sharing your experience. Did you work with occupational therapists or psychologists in your journey of recovery?
I did. I was delighted to learn some psychology from Narinder himself, but we also had an occupational therapy department that was pivotal in my ability to carry on working in the hospital, so that I remain on a university contract as we speak. Only 1 day a week now, but over the period that I started my symptoms and then recovered, I had a contract for 3 days a week. I helped the person who took over from me in the university. I think I've written or contributed to writing about 6 or 7 papers over that 2-year period. And I remain completely engaged with osteoporosis. I was president of the International Osteoporosis Foundation until only a year ago. So the occupational health side of things and the psychological support were very helpful.
Very good. And we've got a question from Jen who's saying, what was the hardest symptom to live with?
Unbelievably, once I'd recovered, when I was very ill, I was unconscious. I was unconscious for probably about 4 or 5 days almost. So at that time, I was sort of facing death. You know, I would have died about say 4 months after the diagnosis of the tumor. But at that point, when I was reviewed by the consultant, the whole of the treatment book was thrown out of the window. We switched from dexamethasone to prednisolone and sharply tapered that off. And I suddenly, instead of going to Countess Mountbatten 3 weeks later, I went home. And 3 weeks after that, I got to where I could start to walk around the house and manage myself around the home, and regained my sort of independence. After that, the hardest thing for me was not being able to drive, because it meant I couldn't get to the hospital. I couldn't get to the shops. I couldn't easily take exercise other than the dog for a walk, or one of my friends and family taking me themselves. Other than that, I would have said that the second greatest deficit was the long-tracked sensory deficit that led to my inability to walk without a limp. And so I had limited activity and still have that. And so I hang on to my friend when we're going over rough ground and stuff like that. Other than that, I listed the in pretty much in order: the loss of memory, not really cognitive decline, that markedly. It was more the sensory long tract signs that were the problem for me, and sleep disturbance, which the magic that they use on airliners, melatonin, has done a great job on.
And somebody's asked, did you have physiotherapy during your recovery period, and did that make a difference?
Yes. I'm a rheumatologist, so I was not the most compliant of physiotherapy participants. I definitely saw the physiotherapist both in primary care and secondary care, and that has helped me put weights on my right leg so that I could strengthen my quadriceps and so on. So I certainly have no complaints at all with the physio that being given to me. My problem is that I wasn't a very good physio patient, and perhaps I should do more. And I'm sure people would recognize that in my obstinacy at home.
And Elizabeth Kuipers has asked this issue about recognizing your symptoms and maybe taking some time to recognize it. Do you think a medical background played a role in that, where you took you some time to accept that your symptoms were significant?
Yeah. Well, I suppose one of the things I've learned is that as a rheumatologist, we're not really neurologists. And so I didn't reckon, I was happier to think that this was a grief reaction. My wife had died of 40 years, and a very happy marriage. She had died only 8 months before I had the symptoms, and banged the car on the gatepost and started the problems with texting and writing and so on. So it was all staccato together into a sort of maelstrom of activity, linked, actually, in my mind, both her and mine, to the COVID epidemic. COVID happened in 20 and 21. 21 end, my wife passed away, and then 8 months later, I developed the symptoms, neurological symptoms of the glioma.
And with the left parietal tumor, just I thought one of the thoughts I've got that people often talk about something they call this Gershman syndrome, and that's left-right orientation problem, finger agnosia, acalculia, and difficulty with writing. Now, I think you mentioned writing was one of the symptoms, but I was just wondering, did you have any of those other three things, the left-right orientation problem, the finger agnosia, or the acalculia? Did that ever come up as a symptom?
So acalculia, definitely. I used to be really pretty good, right from school days. And as a David Barker acolyte, I always think about the early origins of chronic disease. So right from school days, I was good with maths, and I was definitely blunted with that finger hand agnosia. Hard, I would have said hard to say that I had that. And what was the fourth one that you had?
The other one was I mentioned was there was left-right orientation, difficulty distinguishing.
Oh yeah, for sure, absolutely clear for that. Yeah.
We've had a question saying, did you receive any support from speech and language therapists regarding your changes in language?
I did. Actually, one of my university friends' wife is a speech therapist, and so I had both a social and a professional support from speech therapy. To be honest, I'm not sure. Most of the people that have talked to me, I was either completely out or I was okay with language by and large. So in the sense that we can converse in this manner today. Of course, my language isn't as fluent and as sort of internally coherent as it used to be before. I used to love talking, giving talks and lectures and so on, whereas now I'm a little bit more blunted in that. But overall, I would have not said language so much as the physical sequelae of the arm and leg.
Yeah. Okay. Right. And maybe just one last question is that I can ask about memory. You've actually given a very good account and fairly clear account of things that have happened over the past year or two. So it looks like that what we call autobiographical memory is quite good. Do you think that, and then people sometimes distinguish that between remembering what somebody's just told you, or remembering an appointment, remembering things that's a sort of shorter term memory. Do you think that there is a contrast there, that one is affected a bit more than the other, or you think both are equally affected in terms of events that have happened, say?
No, that's a really good question, and I'd have to think about that a little bit more as well. But for the purposes of just now, I would have said that anything that was internally programmed by my work had become such a part of my existence that I was able to sort of save that part of it. Whereas something that was much more mundane than that, like I need to eat some food this evening, or I need to, go to sleep at about 9 o'clock, that sort of cognition did get more affected.
That's very interesting. That yes, and just the very last question. We've got time for one last question. That is, did you have any psychology or clinical psychology input at any stage in terms of your rehab, or to help you with your recovery?
Yeah, I did. As I think I mentioned, maybe I didn't mention it clearly enough earlier on, but yeah, there was a clinical psychologist linked to the department, and I met them while I was in hospital and had I didn't have a therapeutic sort of program. That what has well so far that hasn't been necessary, but it always comes up, and I visit the hospital once a month for my Avastin, and I visit Dr. Ching once a month to be evaluated. And just as my kidney function for proteinuria has to be evaluated physically, my psychological function comes up at those discussions. The nurses have been terrific adjuncts to the consultant and medical staff.
Yeah. Okay, so thank you again for an excellent presentation, Cyrus. Thank you very much. So what we'll do then is we'll go on to our next speaker, and that is Niamh Lowe. And so Niamh Lowe is a clinical psychologist and based in Ireland. And if you're there, Niamh, you can fire away with your presentation. Thank you.
So thank you very much to Narinder for asking me or inviting me to kind of contribute to this conference and organizing it and organizing writing the book and all of that. It's an amazing thing to be a part of today. So thank you. As mentioned, my name is Niamh Lowe. I'm a senior clinical psychologist I'm working in adult mental health service in Ireland. And I am speaking to you today as a brain injury survivor or a person living with a brain injury. So my brain injury was 14 years ago. And in preparing for this and kind of putting together slides and thinking about what I'm going to say, could definitely notice that I was a bit more dispassionate kind of in that, more objective maybe, or rational putting it together. The kind of emotion that was there when I was speaking about it previously has definitely reduced and diminished a bit. So my accident was in July 2010. So I was 21 years of age at the time. I had recently graduated or recently finished my undergraduate degree in applied psychology. And I had secured my first kind of proper job or job in the kind of area that I wanted to work in as a youth advocate. I had kind of a plan, and my dreams or that for the year was I was going to take a year out of academia. I was going to work, gain experience, and then go back maybe and look at child and adolescent psychology. That was kind of the path that I was on, and I was nervously excited about kind of this next stage of my life. But then in July, I had a road traffic accident. So it was a single vehicle collision, or I slipped on oil, the car spun, and I hit a tree. So that kind of upended my carefully laid plans of work experience and masters and moving on with my life as I imagined. But with that accident, I was unconscious, rushed to hospital in an ambulance, and they found also there was hemorrhaging, there was cerebral edema, fractured skull, and so yeah, it was spoken about a severe traumatic brain injury and a diffuse axonal injury. So I was in a coma after that for 10 days, an induced coma. But on waking from that or coming around after that, I was in a very childlike state, or I suppose even infant-like state. So I couldn't talk, I couldn't walk. I was kind of in and out of consciousness, a difficulty kind of recognizing reality from dreams, couldn't pay attention, my memory was all over the place. So impairment in bowel and bladder functioning. So I was wearing, or I had a catheter, had a nappy. So very distressed, very disorientated. I think at that time I pulled the catheter out a few times, the feeding tube, falling out of bed. I was really all over the place. But that kind of settled within a few weeks, and some functions came back within the few weeks. So like my memory came back, I could talk. Some movement, there had been kind of fear that there was paralysis, but there was kind of movement coming back into all parts of my body. So I still couldn't sit or walk, or, I needed a lot of kind of support and assistance in any movement, but I had movement. Continence came back, and kind of orientation to place and person and time came back, attention, memory. So I was definitely less distressed, less disorientated, and I had more awareness and more kind of insight into things. But I suppose as insight and awareness increased, and I kind of was understanding a bit what had happened and my deficits currently, I became furiously determined to recover physically. So, and I'm using furiously, that word purposefully, because I suppose I was filled with an intense anger, and not anger like, why did this happen to me, or I wish it didn't happen, or anger at the world. It was more self-directed, so kind of angry with my own new limitations and angry with the rate of recovery, and it did kind of spill out to anger at injustice or perceived injustice and impatience with other people. But it definitely helped with, I suppose, a physical rehabilitation. I suppose it was like two sides of the same coin, kind of the determination and motivation, putting in all the work for recovery, but then also that kind of self-directed anger and self-criticism. And so yeah, I'll talk a little bit more about that in a little while. But and just to say, when I get nervous, my mouth gets really dry, so I might just take a drink of water before I go on. And then, so yeah, other functions required much therapy, time, and practice. So I spent 5 months altogether in hospital, so between general hospital and rehabilitation hospital. And I accessed kind of the full range of therapies on offer. So speech and language therapy. So I could talk, and I could understand language. The receptive and expressive language was intact, came back quite quickly. But my volume of my voice, swallowing was still a difficulty, pitch. So I spent a lot of time with speech and language therapy, especially initially around even the dysphagia kind of exercises around swallowing, building up the muscles. Occupational therapy was so important. And I know the previous speaker was talking about how it can really help with like independence and, getting you in touch with what's important to your identity. And yeah, for me, I suppose occupational therapy was around fine and gross motor skills, and then the kind of daily living tasks, even cooking and making a cup of tea and budgeting and stuff like that. But also kind of the higher order cognitive functions, so kind of executive functioning and planning and organization and stuff like that. And then physiotherapy, I had a lot of physiotherapy input. So daily I would engage in physiotherapy while I was an inpatient. And that was absolutely brilliant. Like, just so hands-on and so intensive and so motivational and encouraging every step of the way. And I suppose, like, speech and language therapy, occupational therapy, and physiotherapy, all three of them, I met such encouraging, motivating, kind clinicians that really helped so much on my recovery journey. And I am leaving out psychology when I talk about that, because my sole input from psychology throughout my journey was in a neuropsychological assessment. So there was no kind of opportunity for psychotherapeutic support. And I will come back to that. That's kind of the main message of my talk today. But yeah, and to say the neuropsychological assessment was always done in a very friendly, polite, kind way. It wasn't, kind of administered cruelly or anything like that. But I suppose it was purely looking at my functioning, cognitive functioning. So I was discharged from hospital in December 2010, and then linked in with community services, brain injury community services, in January 2011. And my kind of access to brain injury services was mainly, I had a rehabilitation assistant, a lovely man who came to my house once a week for 2 hours, and he was a trained physiotherapist. So we kind of worked a bit on physiotherapy and also social support. He provided that. So I had a really, really positive experience with him. But I suppose the main message of my talk today is kind of my experience of the lack of psychological therapeutic support in brain injury rehabilitative services. So how that maybe had an impact on me. So it's very much my own personal experience. And yeah, it's important to say that I'm not generalizing it beyond. And it's 14 years ago as well. So, things may have changed, and things have changed within brain injury rehabilitative services. So important to say that too. But the reason Narinder had got in contact with me was because I had written an article so in 2015. It was published in 2015 and entitled "I Felt Let Down by Psychology." And it was me talking about my experience of neuropsychology along that rehabilitative journey. And so I reread it again a few times in preparation for this presentation. And this article was published in 2015, but it was written in 2014. So 3.5, 4 years after the accident. And 10 years ago. So something that really struck me when I was reading my words was the kind of rawness of the anger that I still felt. I don't know if it comes across to other readers, but I could definitely pick it up. And I was still hurting quite a lot. And I guess in the 10 years since I've written those words, the anger and the hurt, the emotion has reduced or diminished or kind of moderated. And I suppose I've done a lot of therapy. My recovery, physical, cognitive, emotional, has continued. I've done a master's and a doctorate, so my life has expanded, I suppose, beyond kind of brain injury, working in psychology now. I have a family, husband and a little boy, and a lot of time has passed. But I do think it is still important to honour the emotions and the experiences of that younger Niamh, I suppose, and not to kind of dismiss them because I don't necessarily feel that same level of emotion. So to discuss the article, my experience, my message, I suppose the psychological input that I received in hospital and then after hospital was solely neuropsychological assessment. And I guess I'm kind of repeating myself, but I'm given my own personal experience, so I didn't have any long-lasting cognitive impairment. I'm very, very lucky that that's the case, but this fact definitely altered my view of neuropsychological assessment then, as it did not really seem like the most relevant or important thing to me at that time or after. What did seem more important is that this traumatic event had occurred in my life. I had gone from an independent person with plans and goals for my future to feeling like a child who was dependent on my parents and professionals for all of my care needs. So I didn't know what my future would look like, how much I would improve. I was unable to make long-term plans. And I was also experiencing emotional lability. So I could very rapidly go from intense high to an intense low. So I was dealing with that, and also my emotional regulation skills had decreased, so I was less able to deal with and manage these intense emotions. But despite this, so kind of the trauma of what had happened, the event itself, the subsequent deficits, the emotional lability, emotional regulation difficulty. Despite this, psychologists that I met on my recovery journey were focused, from what I could see, solely on my cognitive functioning rather than my emotional state. So I was trying to work out how best to kind of chronicle this for the purposes of the presentation. And so I kind of, I suppose, want to look at, I'm focusing, I suppose, on my mental health throughout the journey. Because for me, that was probably the most significant thing and something that maybe I think could have been better. But so speaking about that mental health decline, so as I was saying, I was in hospital, the trauma, the distress, the emotional lability, but psychological input is coming in the form of neuropsychological assessment. So I am meeting a psychologist, but I'm sitting down with them and performing hours of cognitive assessments, looking at all executive functioning, looking at attention, memory, language, all of that. And I think what's kind of shocking to think about now is that the most significant emotional support that I received during my stint in hospital was from the manager of a cleaning company. So a patient on my ward had MRSA, so the ward required specialist deep cleaning for a few weeks. So a team were assigned to conduct a deep clean on our ward for a few weeks. And the manager of this team was a woman. And every day or second day or so, she would come and sit in my bed and she'd talk to me about how I was feeling, my confusion, my distress, my despair. We also had a laugh sometimes, but consistently for those few weeks, she came and checked in with me and she saw me, and I had a chance to let out some of my emotions, confusion, fears. She was compassionate, she was caring, she listened. And I remember this so much. She was amazing, but that shouldn't be the pinnacle of my emotional support in a rehabilitative hospital. And yeah, and that kind of sticks out as something that kind of highlights, I suppose, the absence of the emotional support. And then, so I was in hospital altogether for about 5 months, as I already said. And then coming home was exciting. I was very excited for that, but it was also a difficult transition. So I was moving into our rural home with my parents. I couldn't drive. My independence was totally removed. I was quite isolated. And my friends were at the stage of their life where they were traveling, looking at doing masters, increasing their independence, living abroad. And I really felt the gap between me and them. And yeah, so that was very difficult. But I suppose, like I said, I had the rehabilitative assistant that was a qualified physiotherapist, and I was really focusing my attention on my physical recovery. And as I could see kind of visible markers of my recovery, so kind of like, you know, walking with a rollator, to walking with crutches, to walking with one crutch, no crutches, and, you know, being able to, yeah, kind of sit and stand and get in and out of a car. So as I was seeing those visible markers and getting praise from those around me, my self-worth remained somewhat intact. So I was still experiencing emotional ability, and the emotional regulation skills were shaky. But I didn't seem to be kind of, my mood was never low for a very long period of time. But then as my physical recovery kind of plateaued at about 18 months, my mental health began to deteriorate quite quickly. So I'm looking at the time, I'm kind of, okay. So yeah, so my mental health began to deteriorate quite quickly. So I kind of in spring 2012, depression and anxiety set in, and my GP referred me to a community mental health team where I did meet a psychologist in clinical training, but it was more kind of short-term work. But my mental health did stabilize for a while. But even though I was still engaged with brain injury services, I did not receive psychological support from brain injury services or kind of any trauma-specific therapy after the accident. So I kind of pottered on again, and I was trying to piece my life together, kind of constantly striving to get back on track, onto the track before the accident. So I was applying for masters, I was volunteering, researching, so kind of really striving, but not kind of reaching. And seemingly inevitably, my mental health deteriorated further a few months later. And my parents were quite concerned. So they reached out to brain injury services and expressed their concern for my mental health. And psychological intervention did come, but it came in the form of an assistant psychologist performing a battery of neuropsychological tests. So it was over 6 hours, 3 days. And it didn't appear that the assistant psychologist had been briefed about my emotional state maybe before coming to the house. Maybe she'd been kind of recommended or that to do the assessment, I'm not sure. But at the feedback session, she was very polite again, very friendly, went through the results, some recommendations about returning to college. But at the end of the session, she asked any questions, and my mum kind of blurted out about my emotional state and her concerns, and I got quite angry told her to shut up, because it didn't feel like that was the forum. So the both of us were crying, my mum and myself, but the psychologist kind of was a bit confused, or I don't know. Anyway, said, if there's no more questions, I'll be going, but, you know, contact again if you need to, and left. And there was no follow-up on that. And shortly enough after that event, I became increasingly hopeless and experienced suicidal ideation. and wouldn't leave my bed. So eventually was referred to an inpatient psychiatric unit, and I was admitted there for 3 months. And it was there I met a psychologist, and she slowly began to explore the trauma of the accident and subsequent impacts. And I met other young people who were experiencing mental health difficulties and had their own traumas. Might not have been, a single incident adult trauma, but were dealing with their own trauma and subsequent impact of that. So I suppose that's kind of looking at my mental health decline, but looking at my mental health recovery then, it wasn't within brain injury services, but it was within mental health services. So it was that connection with a psychologist, building a trusting relationship where I felt that I could be myself and that I was being seen, that she could, because I felt quite different to the person I was pre-injury. So talking about that person, pre-injury and post-injury, and kind of trying to integrate the two parts, takes time, and you need trust to do that. So then also my expansion of my self-worth beyond my level of functioning. So I suppose this was nearly 3 years after the accident that I was referred inpatient. And for those 3 years, my self-worth had come entirely from, physically improving, cognitively improving, showing my resilience in that way. So expanding it beyond that and kind of looking at the different facets of my personality and my being and beyond functioning. The acknowledgement that I had been through trauma, both the event and the subsequent deficits. And then a lot of it was around self-compassion and kind of recognizing that self-critic had been a fundamental part of my recovery also. So, it's not about getting rid of that, determination, motivation. It was all tied into that critic, but it had become very loud and all-consuming, and was really not helping my mental health recovery, even if it had helped my kind of physical recovery. Recognizing the things that I was continuing to struggle with and asking for support around that. And yeah, like I mentioned, kind of integrating the brain injury into my life currently. So very much it's not just I need to get over this incident that happened and then go back to my old life. It's kind of like this will always be with me. And that takes time as well to accept, but is a very necessary part of my recovery anyway. And then connecting with the brain injury community. So that was through kind of peer support groups, meeting and talking with other people that have been through brain injury, research. So my master's and my doctorate, my research for both of those were around brain injury and interviewing people with brain injury. And my work experience for both as well was in brain injury community or brain injury services. So very much, wanting to be around, and I suppose you're using it, it helps with the integration of the brain injury. But I'm going to speak quickly for the last bit. So my top tips for healthcare staff working with people with brain injury, I suppose, to be aware of the traumatic nature of the injury for the person. So where possible, and I know resources are often something that's cited as to why rehabilitation services may not offer psychotherapy, but it's fundamental. It's really, really important. Be mindful that as the physical recovery slows or plateaus, the psychological and kind of emotional struggles may surface a bit more. So to plan and prepare with the person for that. And that hadn't been communicated to me, or I didn't know that might happen, that might likely happen. And And then just the importance of connecting with the person to try and slow down and build that relationship, and trust with the person, because I guess, yeah, connection and relationship are so important to the recovery. So then top tips for patients. The incident itself and subsequent consequences of the brain injury are traumatic. And understand this fact, and that it is likely, not definitely, but it's likely to affect your emotional and psychological well-being. So I suppose because I didn't meet a psychologist or therapist that kind of said, right, how are you doing emotionally with what's going on? This has been quite traumatic, and you might need to talk about it to try and, deal with and process some of that. That wasn't kind of communicated, and so I didn't anticipate that might be a struggle. One of the really important things for me is naming and acknowledging the difficulties to yourself and to others. So yeah, I find that so important to my healing. Like, don't be afraid to say I have a brain injury. I think it's a joke that I regularly will just blurt it out, because I think once people know I have a brain injury, it allows me to just bring down my anxiety, and I've just acknowledged it. It's not kind of this kind of confusion as to what's going on, why is she a bit clumsy, or why, why is her facial muscles like that, or why, it's kind of, I've explained it, I put it out there, and for me that just helps bring down my anxiety. And then engage with brain injury community. So can help with purpose, meaning, and connection. And that kind of idea of post-traumatic growth. So feeling like something positive has come from this experience. And then to finish, just to say my engagement with brain injury community has been ongoing for the last, I suppose, maybe 11 years. So I've done research and worked with different brain injury services around. One article we wrote is the value of normalization and looking at group therapy for individuals with brain injury. The thesis that I did for my doctorate was called Lonely in My Head, the experiences of loneliness in individuals with brain injury. And I have given lots of talks and tried to contribute where I can to kind of brain injury service user led kind of research. So that is all. And yeah, thank you for listening and for your attention. And I will ask any questions or anything like that.
Okay, so thank you very much, Niamh, for an excellent presentation. We just have a few questions there. Someone's just asking, how are you managing at the present time? Are you coping okay at the present?
Emotionally? Did they specify?
Just in general? No, I think just general.
General. All cognitively, all good. Physically, my balance is, I can't really wear high heels, or I'm quite clumsy. So I'll drop things a lot. I bang into things. I'm always covered in bruises. But it doesn't affect me too much. Like, I run and I do sport, and I'm driving again. So physically, yeah, I'm pretty happy with the recovery. Emotionally, I am doing very well. It's been a long road, and I suppose there's been psychiatric medication like antidepressants, and also therapy has been a kind of an ongoing part of it. And like my emotional regulation, I feel like I have learned skills and ways of helping myself to manage with those kind of more intense highs and lows that I experience now. But yeah, I think across all dimensions, I'm managing pretty good at the moment.
Yeah. And then do you think that do you think in the acute phase, the first few weeks, 1 or 2 months afterwards, do you think then psychological support then is key? I think somebody's asking about that. Do you think that that's in the early stages?
Yeah, sorry, did I start talking before you were finished?
No, just wondering, carry on.
Okay. Yeah, I do think it's important to have someone there. It may not necessarily need to be in-depth trauma processing kind of straight away. Maybe it's more supportive counselling, but there does need to be someone checking in on emotional kind of well-being. And because I know initially, like, I was so focused on my physical recovery that maybe my kind of psychological space to focus on my emotional and psychological wasn't there. And I was still in a little bit of denial, thinking I'll get back to work or I'll get back to college within a few months. But I do think it's very important to have some sort of emotional one-to-one counselling or psychotherapeutic space, at least to touch in with a person.
Yeah. And then do you think that if you compare, say, organizations, somebody's asking about organizations like Headway, and they are compared to say, assistant psychologist or allied healthcare professionals. Do you think that there's any difference in the support that either of them, and do you think that that the allied healthcare professionals should get more psychology support to help patients? I think that's the question they're asking. So there's two things. One is both organizations like Headway, and the other is allied health professionals getting some psychology training or something like that.
Okay, and sorry, the question in relation to Headway is
just to what extent they can provide support, which is maybe similar to or different from what psychologists might provide. I think maybe that's the question.
Okay. Yeah, and I suppose I was linked in, and maybe my experience is kind of impacted by the fact I know Headway, when I was linking in with them, didn't have a psychologist on the team for whatever reason, if it was funding or whether it was they just didn't weren't there to take up the job. But so there wasn't psychological kind of presence on the team. And I do know Headway provides kind of a lot of groups and support that way. I suppose it's difficult when I know I was 21 having the accident, 21-year-old female or woman, and I suppose cognitively my functioning had come back quite well, or wasn't impaired, and sometimes the support groups that are available or were on offer were, I suppose, all males of a certain age, or just not kind of, I suppose, peers, or I didn't identify them as peers. And so, I suppose it's difficult for community services to maybe try and meet the needs of a very varied population of people. But what was the other thing? Psychological support. So people, allied health professionals being trained kind of in psychology.
Yeah.
Well, I do. Yeah, I know within the rehabilitation hospital as well, there wasn't a lot of psychologists available, or psychotherapists or counsellors to do that or to offer that kind of emotional support. So yeah, having more available, having them more resourced in that area, I think would be an amazing kind of asset to rehabilitative services, definitely.
You're right. Okay, well, thank you again for an excellent presentation. Thank you. And we'll just go on to our next speaker then in a few minutes. Thank you.
Okay.
And so our next speaker is Dr. John Scadding. John Scadding is a consultant neurologist, and he worked at the National Hospital for Neurology and Neurosurgery in London. And he'll be talking about his acute and long-term experience of a subarachnoid hemorrhage.
I want to start by thanking Narinder Kapur for inviting me to participate in this meeting. I'm deeply moved by the accounts of Cyrus Cooper and Niamh Lowe, next to which my problems seem trivial. However, there may be some lessons for medical patients and those coming for caring for them in this account of my illness. I am John Scadding, a retired clinical neurologist. I had a subarachnoid brain hemorrhage on the 22nd of September 2004, when I was age 56, now more than 20 years ago. I did not initially behave appropriately when confronted with this acute severe event. Although previously and repeatedly I invited to write about my experience, I have been reluctant to do so, largely on account of the shortcomings of my own behavior and recognition of my lack of objectivity and clinical judgment at the time of the event, and subsequent major personal embarrassment. However, 20 years on, I'm now prepared to share with you the story of my illness and its aftermath. So the acute event was on the 22nd of September 2004. At around 7:30 a.m. that morning, while getting dressed, I abruptly developed overwhelming syncopal symptoms, a feeling of intense faintness and fading vision. I was able to lie down before losing consciousness. I came to within 2 to 3 minutes. I know this because John Humphreys was talking on the same subject on the Radio 4 Today program. I had a severe headache and within a couple of minutes began to vomit. My immediate thought was that I'd had a subarachnoid hemorrhage due to a ruptured aneurysm situated on one of the major arteries arising from the circle of Willis, supplying the brain at the base of the brain. However, there then developed a spectacular migrainous visual scintillating scotoma of the sort I had experienced frequently since my 20s, though on this occasion it developed much more rapidly than usual before resolving in a typically migrainous fashion over about 30 minutes. This visual aura provided a rationale for my denial of what was happening to me. Having looked after many patients with subarachnoid hemorrhage, both as a trainee and then as a consultant neurologist, and knowing the poor prognosis of this condition, still in the region of only 50% survival, despite modern interventional radiological and neurosurgery, I was certain that this was a condition that I did not want to have. So in my acutely ill and fearful state, I thought, could this be a hyperacute migraine? It was a ridiculous thought, and I would have chastised my junior staff for drawing such a conclusion. But I had lost diagnostic objectivity, and only later understood how denial and rationalization of a serious condition could prove to be so powerful and counterproductive. I lay down on my bed. My wife had already gone to work. She is also a neurologist and a clinical neurophysiologist. After an hour or so, I phoned her. I was economical with the truth and asked if she could bring home a triptan for me. as specific treatment for migraine. She did so that evening, and I took it, while disguising from her how wretched I felt. I had stopped vomiting by this time, but the severe headache continued. I slept fitfully that night. On the following day, according to a long-made plan, I decided to travel from London to Cumbria to spend a few days in our small Lake District cottage. It is difficult to believe it now, but I drove the 300 miles there on my own, feeling dreadful, but with my denial and rationalization having received the shaky reassurance that I was still alive. On arrival in Cumbria, I went straight to bed and have little recollection of the next 12 hours. I awoke at about 4 a.m. the following morning with severe headache, neck, back, and leg pain, and severe spinal rigidity. At this point, I could deny the diagnosis no longer and phoned first my wife, then the ambulance service. Haltingly, I explained to the ambulance service that I was a consultant neurologist and that I was virtually certain that I had had a subarachnoid hemorrhage. The ambulance was with me within 30 minutes, and I was taken to Carlisle, where, at about 6:30 a.m., the A&E department was fortunately not busy. The A&E registrar in Carlisle was attentive, but perhaps a little shy about doing a neurological examination on a consultant neurologist. I had a CT scan, and the registrar brought the films to me, saying, "Dr. Scadding, you have seen many more of these than I have." So I reported my own scan, which showed extensive subarachnoid blood in the basal cisterns of the sylvian fissures, with hydrocephalus, in other words, enlargement of the lateral ventricles, indicating raised intracranial pressure. I said to the registrar, "Yes, I have had a subarachnoid hemorrhage. There is no need for a lumbar puncture to examine the cerebrospinal fluid. I think I should go to the neurosurgical unit in Newcastle," which I knew was the nearest to Carlisle. Interestingly, at this stage, I felt I was still in control. The scan shown on the slide, by the way, is not mine, but is very similar, showing extensive subarachnoid blood in the basal cisterns. Next came the ambulance journey to Newcastle, which took about 2 hours. But with the diagnosis confirmed, also came intravenous opioids. The relief from the headache and the back pain and the buttock pain and the leg pain is difficult to describe, not to mention the other therapeutic effects of intravenous opioids. I made phone calls to my wife, son, and daughter in an inappropriately euphoric state. On reaching Newcastle, I handed myself over completely to those who cared for me, so that, at last, more than 48 hours after the onset of the acute event, letting go of responsibility for my own care. This was a watershed moment, and with a sense of huge relief, I understood that I was no longer in control. Over the next 12 days at Newcastle General Hospital, I received the most wonderful care. 4-vessel cerebral angiography, an interesting experience in itself, was followed by an attempt at endovascular treatment with coiling of the demonstrated anterior communicating artery aneurysm under general anesthetic. This could not be safely done. It was a wide-necked aneurysm, and so late on the evening of the 24th of September, I proceeded to a frontal craniotomy and clipping of the aneurysm, which I was later told was not straightforward. I take this opportunity to again thank and pay tribute to Dr. Anil Golkar, neuroradiologist, and the neurosurgeons Professor David Mendelow and Mr. Chris Gerber, without whom I would not be here today. I became conscious of my surroundings the next day, but I was not fully orientated for perhaps the next 2 days. My wife was constantly by my side. My daughter and son also rapidly travelled to Newcastle, and then other family members visited. I apparently rose to the occasion when visitors appeared. My wife then witnessed me sinking back into an exhausted state. The crunching sound of movement in my craniotomy bone flap when I palpated it, and the alarming movement of the flap when I sneezed, are vivid memories. I am told that for a short period I spoke fluent and passable French. An O-level in 1964 is my highest standard in that language, an achievement no doubt assisted by a disinhibition from the opioids I still needed at that time. I have no recollection of this, nor of reported periods of hallucination. Those first few days passed in a blur, when a grip on the passage of time was disturbed, even after withdrawal of strong opioids. I recall head scans, 2 lumbar punctures to relieve raised intracranial pressure, then removal of drains, lines, and the bladder catheter. Sitting out of bed was challenging, as were my first supported steps. There was steady improvement, and I was discharged home to London. I recall the neurosurgical advice I was given at the time. You will be able to do anything physically after 6 weeks, but cognitive recovery is likely to take longer. I thought I felt fine. I was given an outpatient appointment for 3 months. But back at home in London, I sank into a state of severe apathy, energy, and low mood. I stopped taking dihydrocodeine for the headache, thinking that this was contributing to my dysphoria. My wife returned to work, phoning me frequently, but I was on my own during the working day. I experienced cacosmia, in other words, a very unpleasant smell to familiar odors, and this persisted for at least 6 months, resolving into a lasting right-sided hyposmia. This was due to the inevitable neurosurgical disturbance of the orbitofrontal cortex to gain access to the aneurysm. I began to wonder whether I would be able to return to work, but kept this feeling to myself. Doctors get better, surely? At about 8 weeks post-operatively, for no apparent reason, there was an abrupt improvement in my energy, mood, and motivation, and it really was quite a rapid change. As a keen amateur pianist since childhood, I began to play the piano again. I returned to work at the end of January 2005, some 4 months after the subarachnoid hemorrhage. I put on a good show, but in retrospect, I realized I was not fully ready. There were subtle memory problems which I recognized and for which I adopted coping strategies. I guess this problem persisted for several months. I feel certain and sincerely hope that no patients came to harm. I continued to feel very fatigued, a symptom that persisted for at least a year. This gave me an insight into the problem of fatigue as a non-specific but very troublesome and underestimated chronic symptom of many long-term diseases. The prognosis of acute aneurysmal subarachnoid hemorrhage is sobering. Overall mortality remains at about 50%. I fell into the category of good recovery, but a recently published prospective study from Austria, Rass et al., 2024, which I refer to on the slide and which I'm grateful to Narinder for bringing to my attention, indicates that 71% of such patients have cognitive deficits at 1 year following subarachnoid hemorrhage, and mental health issues affect between 16 and 33% of patients. And furthermore, there is impairment in quality of life measures in some 37% of those. I think I'm all right now, but if there is enduring cognitive deficit, I guess I shall be the last to know. One troublesome deficit is a persistent inability to memorize music scores and so to play by heart, something I never had trouble with before the subarachnoid hemorrhage. So on reflection, my loss of objectivity and denial of the obvious diagnosis were frankly reprehensible. But I recognize how fear and a fervent wish not to have had a subarachnoid hemorrhage played key roles in this. They led to delay in definitive diagnosis and urgent care, potentially affecting the outcome. The acute rebleed rate is very high in subarachnoid hemorrhage, not to mention all the family disruption. This life-threatening illness forced me to reflect on my life and reset some priorities. My wife was, and remains, endlessly supportive, and was critical to me making important decisions about the future at this time. Having been, I guess, at the workaholic end of the range, I decided to retire from clinical work before the age of 65. I did so aged 61. Though I continued to work as Academic Dean of the Royal Society of Medicine, Chairman of the RSM's Publishing Company, and Chairman of the Research Committee of the Cure Parkinson's Trust, as a trustee of the Royal Hospital for Neurodisability, and other advisory roles. I am currently chair of a national non-departmental public body. And since the subarachnoid hemorrhage, I've co-authored or co-edited 2 books and have published some 40-odd other publications which are in the public domain. However, I do wonder whether I have persistent cognitive deficits, in addition to the subtle limitation I have in memorizing musical scores. I'm not particularly keen to find out, and feel that I've functioned reasonably well since the subarachnoid hemorrhage. Should I have had psychometric testing, and might I have been helped by psychological therapeutic input? I look forward to hearing your observations on these matters. But perhaps there were those who thought that, as a doctor, I would be able to recognize and draw attention to my problems, and that I would be able to deal with them better than average without help. My final thought is that now, as then, I would actually always seek to choose to deny that I have health problems. My dear wife knows this. I am eternally grateful to her and those in Newcastle who saved my life. Narinder asked me to provide some top tips, drawing on my experiences, both for future medical patients and for healthcare staff. So for medical patients, I would recommend, first, try to be objective. You are as vulnerable as anyone else. Stoicism is not always the appropriate behavior. Second, accept that you need help, that you need to let go and hand control to others. And third, submit yourself to care sooner than later. And secondly, for healthcare staff, I would recommend be objective. Doctor patients are always well informed, but always biased. And secondly, doctors as patients may be reluctant to be on the receiving end of care. They were trained that it should be the other way around. Thank you.
Presentation, John. And what we'll do is just there's one question which is there, and I was going to maybe expand on that. So, did you have presume then you didn't? The person asked about whether you had any cognitive assessment during either the acute or later on, or do you think that that was something which, if you didn't have, you might have benefited from, or?
No, I didn't have any neurocognitive assessment, Narinder, and maybe I should have done. I suppose I was probably over anxious to try and return to work. I'd always said that there were a few investigations I never wanted to have. I mean, long preceding this illness. One was a head scan in case they found that there was something there. The other was psychometric testing in case they understood how unintelligent I really was. But those are perhaps throwaway comments. But the answer is no. I did not have and was not offered a psychometric assessment. And in view of the paper that you kindly shared with me, perhaps I should have.
Yeah, so there's one thing then is the neuropsychological cognitive assessment, and then the other side of it is the psychological support, either what we call cognitive support or emotional support. Do you feel that you could or should have had that, and that would have helped if at various stages, especially getting back to work and maybe deciding to retire from clinical practice? Do you think that if you'd had either cognitive or psychological support, that would have made any difference to your decisions then?
Yes, I think they probably would, and might have suggested to me that I should have retired earlier. But as I said, although having retired from clinical practice at the relatively young age of 61, I have continued to do other things where I suppose poor decisions are less dangerous to patients. But I feel I've been sustained by continuing to do the work that I've done.
And someone just asked let's see now, is there anything the therapists could have done further to aid the transition home and integration into the community and return to work? Because sort of overlaps a little bit with what we've just covered. But is there anything that you think they could have, people could have done more to help you get back to a community and home life and work life?
I think it's difficult to answer that question, really. As I've already alluded to, I have fabulous support at home from someone who is herself a neurologist and neurophysiologist, and a very supportive family. I really don't know the answer to that question. I think maybe the question could be put to to my employer at the time, asking, is this man safe to return to work?
Yeah, and so somebody's just asked the question then about demonstrating fitness to return to practice. Do you think that again, that should be for people in Europe, and not maybe just yourself, but in general? Do you think that that should then be a formal thing in terms of fitness to return to practice, and should be formally assessed? And somebody just asking about enrollment of occupational health and things like that. You think that all that should be formally sort of in place in these sort of situations?
Well, I think so. In relation to fitness to practice, I realized that I had no formal assessment. It was, I looked the same, and I could respond in a reasonably articulate way, but that was, of course, no guarantee that I was fit to practice. So I think, yes, maybe the threshold should be lowered for the insistence on a formal assessment, which, of course, should be multidisciplinary. I mean, in retrospect, of course, I'm glad I didn't have to go through that, because one of the effects of such assessments is to reinforce in the patient the the idea that they have been ill and that they may not be capable. And that, I think, is not always a good thing. But I'm a man of my time.
And yeah, I mean so it was an anterior communicating artery, and in theory there was blood in the frontal lobes, and you mentioned about smell, I think, being a little bit one of the residual deficits. I mean, people often when they talk about behavioral changes and things like that, and after lesions in that sort of area, they contrast the two things. One is a degree of apathy, and the other is a degree of impulsivity, maybe a slight disinhibition. Are you aware of either of those things now as residual things, either a slight degree of apathy or a slight degree of impulsivity? Is that something which comes up or that you're aware of, or you're not really, that doesn't come up?
No, I think the opposite of apathy. My previous rather chronic anxiety and concern about events has returned, and that's intact. I suspect that emotionality is a bit more of a problem. I cry when listening to certain music in a way that I perhaps didn't used to do. And as to other executive functions, I suspect that the control of my appetite is not as good as it used to be. But these are fairly subtle changes, and perhaps you can understand that I don't want to, as it were, share everything.
And then there's an interesting one that you mentioned in terms of an observation about learning the musical scores, and and you say that that's something which you used to be able to do well, but now is a slight issue for you. Is that right? Is that something that
It is, absolutely, absolutely. I mean, I started playing the piano when I was 6 years old, and I would practice pieces of music, and they would be in my head like this.
yeah.
And I could continue to do that until around the time of the subarachnoid hemorrhage. Now I really need the notes in front of me, the scores in front of me. I can memorize a certain amount, but not as I used to. It's a subtle change, Narinder, but I think it's real.
Yeah, I think it's interesting because it's possible that, because I think people could argue that if there was a bit more right frontal involvement, either in the access to the surgery or the lesion itself, that in theory the right hemisphere deals a bit more with the music, and the right frontal would be sort of going about trying to problem solve or learn these things. And so you could argue that that could be related to the actual location of the either the surgery or the lesion, but there's obviously that's a bit of speculation.
I think so. I mean, I have a right frontal craniotomy. You can barely see it. It was a terrific craniotomy, although the lesion was actually slightly over to the left. And the damage to the orbitofrontal cortex is minimal. So I don't know.
Just maybe just the last question. Somebody's asked, as a healthcare professional treating and caring for a fellow healthcare professional, what advice would you give in relation to communication with a healthcare service user? Did anything stand out that was appropriate or not appropriate? So whenever you were getting advice, things like that, do you think that there are things which maybe in terms of communication which were said rightly or wrongly, and that might, was there anything that came up in terms of communication from others to you?
Yeah, I think it's a two-way street, Narinder. I think one needs to overcome the reluctance, me as a consultant neurologist, to engage very freely with everybody who's trying to help, and exactly the other way around. That there are those who sort of perhaps regarded my state as a consultant as different, and therefore were reluctant to engage with me. And somehow one needs to cut through that reluctance so that there is the freest possible engagement. And that way, I think all the answers lie.
Yeah. And is fatigue still an issue? And if it is, do you use any strategies to deal with that?
No, fatigue. It was a very considerable problem for at least a year following the event, which is remarkable. One has to say, well, why should that be? I was fully recovered and so on and so forth. But I think fatigue is increasingly recognized as a feature of many long-term conditions. Of course, in neurology, in multiple sclerosis, it's been recognized for a very long time. But for example, the leading symptom in a group of long-term sufferers from rheumatoid arthritis, reported by John Kirwan and others some 20 years ago, chronic fatigue rather than joint pain was the worst symptom. So it's a very important long-term and severe symptom in chronic disease in general.
And but are you getting fatigue now? No.
No, I think not over and above what I would expect from my 76 years.
Yeah. Okay. Right. So that's very good. It's very good that you've recovered from that, really, and that's excellent. So thank you again for your excellent presentation. That's been very informative. And what we'll do now is we'll have a lunch break where I'll be showing some slides of books and podcasts and webinars which doctors have written about their condition or spoken about. first speaker this afternoon is Professor Alex Mitchell. Alex Mitchell is a consultant psychiatrist and professor of psychiatry at the University of Leicester. He's well known for his work on psychiatric care of patients and new developments regarding AI in medicine. He had a successful research career. He will discuss the impact of COVID on clinicians from his own personal experience.
Thanks again for the kind introduction. It's nice to be here this afternoon. Today I'm going to be talking about my experience with COVID. Clearly, this is a massive issue for the whole of society, and everyone has had an experience of COVID in some way. I'm going to be presenting my personal side. Some aspects may be new to you, some may be shared. The way I thought I would do it was tell you about my acute and long COVID in two parts. And then if we get time, I can talk about my impression of how society handled or mishandled, depending on your view, COVID as a whole. Obviously, I'm not going to go into great detail, but maybe just touch on that, and then a few Q&As at the end. So essentially, just a couple of background slides. I started medicine in 1987 in Newcastle upon Tyne. I trained mostly as a junior doctor in Cambridge. Then I went to Leeds as academic lecturer in psychiatry, and then finally got my consultant job in Leicester, and then became honorary professor in 2009, University of Leicester. So I've had, a good experience around the country to see how things are done differently in different cities, if you like. Now, I can talk about my experience here as a clinician, as a professor, as a psychiatrist. Some of the things I'm talking about today are psychiatric symptoms. So what is it like for a psychiatrist to experience psychiatric symptoms? Is it an advantage in the sense, presumably, we have, more information than average about what's going on, but not always an advantage. You're still a patient at the end of the day. And as I said at the beginning, this is a personal story, not necessarily a success story. We've already heard some of the great things that healthcare has done to help previous colleagues. I would say this is not a success story I'm presenting. This is more like a story of lessons. What should we learn from what I'm going to describe here? So let's start with the acute COVID experience. At the time, 2020, I'm talking about September, I was working on the front line, consultant job. Actually, around that time, a lot of colleagues were off sick for miscellaneous reasons. There was no vaccine then, no offer of vaccine. There was minimal PPE. I mean, the PPE that we had was shocking. I'm talking about rags of plastic, really nothing. I just can't see how they would be effective to do anything, really. And we had no effective risk assessment. I mean, look how big the NHS is on risk assessment. We are constantly going to training courses on risk assessment. But when it really made a difference, there wasn't a risk assessment. Or let's put it this way, it wasn't effective. My manager did make me do a risk assessment score of COVID risk, and he came out as 12 out of 13 on our local scorer, i.e. extremely high. I was already engaged with ENT for a medical problem at that time. That's one of the reasons it was high. But they said, oh, you'll be fine. No, it's okay, don't worry. So what kind of, we had such poor understanding of COVID then. How could they say that? But anyway, I was on the front line. I was actually up all night on a particular night. I remember as the outbreak broke out, minimal PPE. And sure enough, after 1 or 2 weeks after that whole night shift, it was just me and one junior doctor, I became unwell. And how did I become unwell? Well, I did have some typical symptoms you'll all recall, like fatigue, headache, flu-like symptoms were the norm. Yes, I had those. But then I had, I would say, more peculiar symptoms. I had really severe insomnia, the kind of insomnia that's hard to describe, but essentially I was extremely tired, but couldn't sleep, couldn't settle. It was like the part of my brain responsible for sleep had been removed. So I was desperately tired, but couldn't sleep. I would say I was getting around 2 or 3 hours a night only. And then that was mixed with tinnitus, which obviously you're familiar with, a high-pitched tinnitus that is pretty common in society. But I had this weird high and low-pitched tinnitus. So the high-pitched tinnitus, I actually have it now. It's never completely gone. But the low-pitched tinnitus was like a rumbling sound. And I used to try to get the explanation for this tinnitus. Like, what is it in my environment that's causing this? Surely it's not generated by my acoustic system, by my brain. I just couldn't understand it. So I'll be looking for an explanation. I remember one very disturbed night. I was not sleeping. I was probably going into a delirium. And I heard the sound of a gate banging. And I remember thinking to myself, could this be a hallucination? Because I really feel myself unwell. I feel like I'm on the edge of psychiatric symptoms. And you know what? I don't know how to prove or disprove it, because let's say in the middle of the night at 3 a.m., I go searching for this banging gate and don't find it. That's an extremely worrying type of behavior. But let's say I don't go looking for it and just lie here anxious and on edge. That also is not good. It's like a catch-22 in that situation. So this was the beginning of a more serious problem. Concentration began to deteriorate, and I had this phenomenon, I think we heard about it from John earlier, of abnormal emotional regulation. Actually, I did a study on that in Leeds on what we called then emotional disinhibition or pathological emotionalism, where essentially you become very quickly emotional relative to the stimulus. And it can be a positive, like you can really appreciate something, like you can super cry over a love movie, for example, or you can get really upset about what's going on in the world. And I definitely had this in this kind of psychiatric, neuropsychiatric prodrome. Then I began to get more kind of frank psychiatric symptoms, misidentification. I thought somebody on the ward was an old professor that I used to know. And it wasn't like I half thought it. I really thought it was like this person. Like, it wasn't like, oh, I'm not sure they look like this person. No, this was him. So I would be like, oh, how are you? I haven't seen you in a long time. Crazy. Then I had this idea of delusional perception, where you see a signal, something in your environment, and it represents like some kind of special significance. And this began to get systematized for me. I put this rebus principle. It's from the evolution of languages. It's essentially how I was reading a lot of books on languages at the time, how languages represent their phonetic sounds as characters, which were previously ideograms or like hieroglyphics. And I began to think, well, surely humanity didn't come up with this. It's so brilliant. This system is just amazing of language. Maybe we were given this system by aliens or something from outer space. And then I began to think, yeah, I'm going to look for the signs of that. So, beginning to get quite into the psychiatric domain. But bear in mind, I was also physically unwell. I had a low resting heart rate, around about 30 to 35. I had a low max heart rate, so I was quite fit. So you might say, well, that's just sinus bradycardia. But I was fit with a low max heart rate as well. So I had a low heart rate reserve. I was dehydrated at that time with high ketones, a slightly abnormal white count. And moreover, this phenomenon that I'm describing now was quite acute. It really developed within a few days. But within a few days, I had pretty much lost insight, at least in the traditional superficial way that you might describe insight. So let's just talk about that for a second. I felt like I was unwell with a possible psychotic condition, maybe psychiatric, maybe delirium related. The origin wasn't clear, but I could see I was in the middle of a lot of symptoms. But here's the kind of paradox of this. How could I kind of get out of it? How could I get out of it? Because it just seemed all quite convincing that these things were probably true to me at the time. So much so, I would say that the belief system kind of overrode COVID itself. I began to think COVID at that time was so unlikely in society, that like the way it was presented, the amount of millions of people that had been affected, and the just gross impact all around the world, that maybe COVID didn't exist at all. Not that I'm saying now it doesn't exist. Obviously, I'm acknowledging it now. I'm saying at the time, I thought that maybe my brain had invented it in a delusional system, because if you actually look at it at that time, when it was so poorly understood, it is quite fantastical. So I began to think to myself, look, I'm unwell right now. This is an acute presentation. How can I detach myself from this psychosis? Now, the more normal thing to do would be to take some medication. Now, I didn't have access to medication at that time. So I thought, okay, how long have I had these symptoms? Okay, so let's say a few days. Are any of the symptoms clearly biological? So they're not psychiatric, they're clearly biological. And can any of them be manipulated by me? So I thought, okay, I've got a brilliant idea. I will stop eating and drinking. Because if I deteriorate through not eating and drinking, surely that proves that it's physical. And if I don't deteriorate, maybe the entire thing is a massive psychotic belief with a very systematized delusion. And really, maybe I'm not experiencing any of these things in the way my mind thinks I am. So I began to not eat and drink. So that was not advisable, but I can see now why I was doing it. Anyway, I was admitted to hospital. That's the positive thing. I was admitted to hospital by ambulance as an emergency and spent 4 days in. And that was quite a rough period. But there were positives. I mean, I began to really kind of get a better grip of psychiatric symptoms that, you can have problems with identifying people, places, sounds, feelings, self, mood, visual, the things we learn as a student, they became more concrete to me. Like, yeah, I can see why that happens. And I can see why it could happen to anyone. If you start to dial down your ability to distinguish between self and others, so the precision that your brain is separating yourself, like the boundary areas, then all of these assessments are going to potentially become problematic for you. So let me tell you 5 clearly bad things that happened to me whilst I was in hospital. So the first thing is I was unwell. Let me just say I was unwell. I had psychotic symptoms and they had a manic flavor. So they could have been schizoaffective. It could have been, like a rapid mania almost with psychotic symptoms. And so I don't mind at all that my psychiatric colleague came to see me to help. I mean, that's his job. I appreciate that. But what he did was a little bit odd, in my opinion. So he said to me, okay, you're unwell, and I recognize that, and I'll try and help you. I'll be back tomorrow. Okay, good. What time? Okay, 8 o'clock. 8 o'clock in the morning before my ward round. Okay, 8 o'clock comes, no doctor. 9 o'clock, 10 o'clock, no doctor. Now, I had no phone. I had no nearest relative. I had no family member. They were all banned from seeing me because of COVID. COVID meant we were not allowed to have a nearest relative contact. At least that was the rules when I was admitted. I had minimal, initially, food and water at the time of being admitted to A&E. So I was in a very vulnerable position, I felt. And this doctor who had promised to come and complete his assessment didn't come back. So I thought, what can I do in this position? I thought, well, I am a doctor in this hospital. I'm literally a doctor in this hospital, and I'm suffering from a kind of isolation in the hospital. That's not right. So what I'll do, I will just ask the ward to give me the phone and then ring switchboard and ask the switchboard to put me through to the secretary and the secretary to put me through to this particular doctor. yeah, why not? And they did. They literally gave me the ward phone, which I was quite surprised. So I got through to the secretary and said, let's call him Dr. Smith. When's Dr. Smith coming to see Dr. Mitchell on the ward? Oh, he's coming very soon. Okay, great. But when he came very soon, he came with armed to do the section, the Mental Health Act. So the reason he wasn't available was because he was preparing to do the section, basically. He didn't want to tell me. And then eventually my mum was able to get through to me by phone. And that was a relief, you know, because you suddenly get that connection with the real world. And my mum said, Dr. Smith has rung me to get your early life history. I said, my mum said to him, why don't you ask him yourself? He's your patient now. You don't need to get it from me. He said, oh, I don't want to say too much because we're trying to section him. Okay. And by the way, don't you, my mum, don't you tell him that I'm trying to do this. So what an awkward thing to say. Why would you do that? So anyway, they did attempt to do the Mental Health Act assessment. And I don't mind the Mental Health Act assessment if it's appropriate. Done well, you know, without an imbalance of power, it may in some circumstances have been appropriate, of course. But they came in like they're determined to do what they wanted, not that they were listening to me. And actually, it took them roughly 2 days to get their act together to come. And my condition was rapidly deteriorating and rapidly improving, and really improved with benzodiazepines, I'll be honest. Just quickly, when I started on medication like diazepam, I started to feel rapidly better. Actually, the first thing that helped me feel better was quite funny, because I wasn't eating and drinking very well. And I'd been pushed into this glass side room in A&E. It was almost like a zoo. And this one really abusive member of security was like swearing at me and pushing me around when others weren't looking. By the way, this wasn't a delusion. They were most of the security staff were really nice. There was just this one not nice person on their shift. And what happened was I then went to medical assessment unit, and this a very nice lady, domestic member of staff, came around with a trolley with sandwiches. And at that time, I was still unwell. Remember, I was still quite psychotic insight was quite low. And I was like, I'm not even sure I'm in hospital right now. And then she said to me, oh, how are you, dear? Would you like a sandwich? And I was like, whoa, this lady is really kind. I said, how many am I allowed? And she said, as many as you like. I was like, I don't need to be worried whether this is a hospital or not. This is someone trying to help me in a way that I feel safe. And literally from that moment, I started to recover, because it was a connection back to reality. Anyway, so after that, they tried section number 1. It didn't go ahead because I was improving. But the next day they came back for the second attempt, a new bunch, if you like, the 2 doctors and the social worker. And the only reason that didn't go ahead is I made a speech to them, which was basically saying, this capacitus patient, capacitus meaning you have capacity, has weighed the pros and cons, has heard what you've got to say, is aware of his history, is willing to take medication, is willing to take the least obtrusive option. There is no need to admit me under section to ward X, Y, or Z. Oh, yeah, okay, we'll have a little conference about it and come back to you. Okay, fine. I said, if you're going to go ahead, I want to record this and I want an advocate in the room. Oh, okay. Like, it's a really strange thing. Now, this is the problem with the Mental Health Act. There's a power imbalance in it. And you might know the Mental Health Act is going through Parliament for revision right now. But I'm not impressed with the revisions that are being proposed. It doesn't equalize this power imbalance that is implicit in having 3 basically professionals trying to do something to one patient with no one else in the room. It just doesn't really work. And I've seen it from the other side many times, but I've never really thought about it, because when you're the professional, you think you're acting in the patient's best interest every time. But that's an assumption. So at the very least in the Mental Health Act, there needs to be some kind of advocate system. Okay, so I was initially denied medication. Yes, that's true. But later, I did receive medication and start to improve. Now, let me tell you 5 good things that happened to me. So I was treated with kindness by the domestic staff and the most of security, except one. In fact, the other security guys were lovely to me. I was like, I'm stuck on this ward right now. What should I do? They said, okay, come for a walk with us. Get some fresh air. You don't need to stay right here. The other guy was like, you're staying here, and if you move an inch, I'm going to hit you. Well, gosh, does this really exist in the NHS? So I learned my own limits, of course, like a bit like being disinhibited on alcohol or drugs. You're suddenly aware your brain has a lot more capacity than you use day to day. I mean, you can't normally use it because you would be making crazy connections left, right, and center. But some of those crazy connections are correct. It's just that your filter is off at that time. Mental health, like I've mentioned, I've said that humanity basically is rich in the hospital because, so many nice people there, but they were not generally, I'm sorry to say, the high-powered clinicians trying to do their busy job. They were too distracted. They were too busy. Some were good, but nearly all the bottom, like normal staff that were doing the hardest job with the least resources, least thanked, they were the ones that I related to most at that moment. So I did rediscover the importance of being grateful, and I hopefully have kept that with me. So let's go on for a few minutes about the next phase, which is long COVID. What happened in long COVID? Well, yeah, basically these symptoms that were these awkward gray area symptoms were not resolving. I went to see cardiology. They said, oh, we're not sure what to do. We don't understand COVID very well. We see a lot of different things. We don't know what tests to do. We don't have any treatments. I had this severe insomnia. They said, we don't know what to do. It's COVID. We don't fully understand. We don't have any good treatments. There's no good medication. I had this severe tinnitus. Okay, tinnitus is tough to treat anyway, I admit. And then the resolving delirium, I was referred actually. I mean, delirium clearly is a psychiatric manifestation of an organic brain disorder, but yet I was referred to psychiatry for that. So there was a problem there. But I just kept getting this reply, oh, because it's COVID, we can't be certain, we can't make a decision, we don't know what to do. So Aki Health, okay, well, should I go back to work anytime soon? Oh, I'm not sure. Should I consider early retirement? No, probably not, because we don't know what's going to happen. I was like, but it's been a year. Okay, so let's look at the timeline. Let's look at the timeline of this. So September 2020, I had the acute COVID, more or less 4 days admission there. Then it pretty much went straight into long COVID with no good period. Like it just dragged on for a long time. So December 2020, my case was being raised. I was unwell, but it took a year to be referred anywhere. The first thing I received was online support. I'll talk about that in 1 second. And from there, so that's a year later, it took 1 more year to access long COVID services directly. And I received rehab, and the rehab was excellent in Leicester. The long COVID program was excellent, except it was extremely short. So I did 2 to 3 days a week for 6 weeks. But I'd been, by that time, I'd been unwell for nearly 2 years. So was 6 weeks going to get me back? I don't think so. They needed more. I did a little bit of research, and I was very keen to find out as much as I could. And I had time on my hands, so I was looking into all these, what's the origin of long COVID? What's the biology of long COVID? Is there any evidence for X, Y, or Z? And, the answers were very poor. I mean, this paper from Lancet Psychiatry 2022 compared 1.2 million with COVID with 1.2 million with other respiratory matched infections. And with COVID, there was a higher cognitive impairment. there was a higher muscle involvement, there was a higher rate of psychotic disorder, and later there was a higher rate of dementia. So there are potentially some real differences. But typically, you know, we've got a mixed bag, haven't we, of multiple symptoms, and we don't necessarily know how to handle them. But for sure, in various studies in long COVID, fatigue goes on a long time and cognitive impairment goes a long time. And when you ask what is the origin of all these, you really cannot find an answer, because the answer could be almost anything in any area. It's definitely not one condition. It's multiple conditions. And in some people, it might not even be biological, meaning that psychological factors are going to have an important component. We don't need to be scared to say that. That is the same in many conditions. Psychological components are common secondarily or with the condition or even as a precursor. So let's take that on board, and it will be different for each person. I understand it's very hard to make a simple summary, but we can try and make advancements, can't we? So in the long COVID period, the first thing I got was the support group that was online. Actually, it was two. It was miscellaneous support with kind of random COVID patients, which wasn't really very good. And then I got the doctors with COVID support group. I think that was from Facebook. But I didn't find their messages helpful. Now, I don't know whether they're kind of stuck in this sick role, but whenever a question came up, the answer they always gave was rest more, rest more. I'm thinking of going back to work. It's too early. Rest more. I want to engage more with the community. Rest more. I mean, medicine has moved on from rest more. You know, the principles of rehabilitation are start slow, have a goal, build up slowly, allow yourself to have ups and downs, but aim to go forward. Be active, not passive. Be your own advocate. These are the principles, not just rest more. So I don't know whether that's changed now, but that was my impression. Occupational health, they only really wanted to talk about vaccination, and that was long gone then. I never had vaccination. I mean, I'd had 2 or 3 episodes of clear COVID, and I'd been in hospital, and I'd had long COVID, and I'd basically recovered. And now you want to talk about vaccination. It doesn't make any sense to me. They were conflicted also regarding coming back to work. So what happened? Occi Health should be providing like a link between you and the employer, but my employer was extremely harsh. So during this period where I was off for over 18 months, almost 2 years, trying to go back, trying to get well, they sent me 2 letters saying your contract's finished. You should go. It literally said you should go to the job center now. Nothing else, not thanks for your career, nothing about you. Were you a really good colleague to work with? No, just bye, job center. The only reason I didn't get sacked was because the BMA said the government is protecting these jobs at this time. In fact, the government insisted you pay protected for roughly that 2-year period. And the only reason I got paid was because it was pay protected. The trust tried to not pay me during this time, even though they were in a massive argument with my BMA representative about paying me. And during this time, they also deleted my job. So my entire role, which was liaison psychiatry, psycho-oncology to the cancer department, was deleted at the beginning of COVID. So they said, come back, but we'll send you somewhere else. And if you look at the statistics on this from the BMA study of 600 doctors with long COVID, 60% had suffered persistent ill health, 50% had lost earnings, and about 10% or more had left the NHS. And that might be even more in social care and social services, because those guys were sacked for vaccine worries and vaccine hesitancy. You weren't allowed to be in social services and say no to vaccination. And that was even when we didn't have the full story of vaccination. So look, time is short. I'll just do 2 minutes on the big story of society and COVID. But in a nutshell, it's been bad for everyone. I mean, there's no surprise there. It's been a failure in so many ways. And I don't think the COVID inquiry is looking into all these failures. I think fundamentally, it's a failure of science or power. Like, I had this idea that doctors were in charge of medicine, and it's so clearly not the case. Managers are in charge. The government's in charge. We just do what they say. And is science in charge of doing what was right in COVID? No, science was not in charge. There were almost no studies except modeling studies. Work was disrupted, education was disrupted, earnings were disrupted, social life, health, social events. Were they necessarily disrupted? Well, only if you can prove that the disruption was necessary. It's impossible to prove now. Most real life studies say that the result, the response was worse than the condition. Now, it's very controversial because anything related to counting COVID or COVID deaths has been so messed up that we literally can't sort it out now. It's such a mess, like the data is such a mess. But I would say everyone is kind of culpable. And, you know, I include us, we're all to blame in some way. We stopped routine face-to-face work. Okay, we were told to. We discharged patients prematurely. We gave them inappropriate drugs at times. We used the Mental Health Act inappropriately at times. They're just examples. Patients were sent back to their care homes prematurely. Institutions were closed, but no one asked, should we be doing research on these things? Managers were in charge. They hid the rates. We couldn't argue. A lot of climate and fear. Media weren't asking the right questions. It was horrible. And the studies that were done were nearly all modeling. And even in the COVID inquiry, they've admitted we modeled for the worst case scenario to give the answer the government wanted. It's not good. Now, I'm not going to go through this, but I did start to unpick all of the grid of did this work for this, and basically the studies are so bad. Even on masking, you may have strong opinions on it, but it's not been an area of scientific joy and success. Okay, a good paper to read there is the Cochrane Review of Physical Interventions to Interrupt or Spread Respiratory Viruses, Thomas Jefferson, 78 studies, updated last year. And why, we're getting the last two slides now. Why did science fail? Well, there's loads of reasons, but data was censored. We didn't have access to it. If you were going to lock down, and Leicester, where I am, locked down first and came out of lockdown last, cluster randomize each county and say, let's look at what is best in each one. We shut down any contrary voices. We ignored obvious harms. We gave interventions to really low-risk groups, particularly in the USA. We didn't really admit we don't know, let's find out. Yes, sometimes we said we don't know, but we didn't say let's find out. And we were led by politicians rather than opinion leaders in our field. So what are the take-home messages? The take-home messages for me are that we did very little well as a society, but we did a few things well. For example, we looked after the homeless. We took the homeless off the streets. That was amazing. It was amazing we did that. But then we reversed it. We showed ourselves capable of such compassion and then said, forget about it. They can go back. We worked hard in very, very difficult circumstances. I totally admit that. And information has been given so badly that I don't blame anyone for their view from one extreme to the other. I don't blame anyone. My case was personally fairly mishandled, but was it mishandled more than other people? I don't think so. I think other people got an even worse experience. And I personally feel I grew from it. I learned from it. I benefited. I learned about myself, the system, mental health. These are all positive experiences for sure. So what would I say to other patients in the future about living with a disease which can become chronic? Just the same principles as before. Aim to go forward. Yeah, you may feel stuck. Don't compare yourself to the previous baseline. Take small steps, go forward, take it slow, ask for help, get people on your side. Be an advocate for yourself. If you need to, and sadly you do these days, fight for your health with the NHS if necessary. Maybe you need to be creative or inventive. Help each other online. There's so much capacity to do that now. And for staff, well, the fundamental is ask, what can you do to help this patient? And you do that right. But you need to do that going forward with better science and listen to the patient. You know, we haven't listened to patients enough in the past with controversial conditions. Use the principles of rehabilitation and help each other, as always. All right, thanks, guys. That's my overview. COVID-19, my personal experience. Very interested in any comments or questions.
Okay, so thank you very much, Alex, for a very interesting presentation. And at the moment, we don't have any particular questions, but if I could just ask a few things. First of all, sorry, let's see, well, hold on, we've got one or two things, one or two comments, but let's see, nothing in terms of a question as such. When you got your rehab, did you have any occupational therapy or vocational rehab at that time? Somebody's asked that.
Yeah, I mean, not true OT, but the team that I had was multidisciplinary, and credit to them. They were trying hard and they were getting a lot of referrals. Incidentally, after I felt I'd recovered, I did offer my services to join them. They haven't taken me up on that as yet. Maybe it's a conflicted area, but I totally support the idea that we should have occupational therapy, but it was mainly physiotherapy that I had in terms of rehab. And it was kind of owned by respiratory medicine. Respiratory medicine were the department that kind of created that.
On so in terms of your actual recovery now, in terms of either cognitive or physical or psychological symptoms, you feel you've mostly 100% recovered, do you think?
I would say I'm 90% recovered. And, you know, like it's very hard to say I'm completely recovered. I definitely still have residual symptoms, like the cardiovascular tone is not 100% normal, and the tinnitus is not completely normal, and sleep is not completely normal. What happens is it becomes so slightly abnormal that it kind of merges with everyday life abnormal. So like if you have a bad weekend or a bad night's sleep, you're like, well, it's not, is it COVID? Well, I don't need to worry now because it's in the zone of just normal life. So I can pretty much manage my current symptoms. And then when I went back to work, I mean, I did face a huge challenge going back to work because my department was deleted whilst I was off. I basically went back to having no colleagues, no department, no secretary, which I had previously had, no goal, because I'd lost my core working goal. So I went back and had almost nothing to give. And that's the worst situation to recover. Like, how does that help you recover? Aki Health said one accurate thing. Well, no, they said a few things, but they said after 2 years, very few people go back to work successfully. So I was in that very small group, but then the employer made it so much more difficult. So, you know, in a way, I'm fighting areas that are not directly COVID related. It's about my employer, the NHS, the waiting list, you know, too many patients, the normal things now. But do you have the energy, the resilience, the concentration to fight those normal things? I would be totally honest and say, for 6 months having returned, I didn't feel like I was doing anything like a normal job. I was struggling with the basics of work. Just going in, I found a challenge. Just literally going into the office was a challenge. So
well, very well done for being able to get back into things to some extent. So what we'll do is we'll leave it like that now. We're going on to the next talk. So thank you again for your excellent presentation. And we're going to the next talk now, which is from Professor Morris Moscovitch, who'll be talking about his right hemisphere stroke and partial recovery. So Morris Moscovitch is a cognitive neuroscientist attached to the Department of Psychology at the University of Toronto. And also he's at the Rotman Research Institute, and that's also in Toronto. So I'll hand it over to Morris to load up his slides and present his talk.
I've been following all the talks, and they're terrific. I'm really enjoying the conference. Thank you, Narinder, and your colleagues for organizing it and for giving me a chance to speak. So I'll be talking about right hemisphere stroke that I had on in June 26th, 2022. So it's a little over 2 years now. And you can see that I can still talk and I can do some things, but you'll find out just how much the stroke has affected me and what my recovery was like. Okay, just to give you an idea of where my stroke was, I don't know how sophisticated the audience is, so I'm going to keep things simple, at least in terms of the neuroanatomy of my stroke. So my stroke was a right hemisphere stroke in around this region and this region. And you could see how it had affected. This is the right hemisphere. This is the motor cortex. So my stroke affected this area around here, slight weakness in my leg, my left leg, and this area around here with considerably more weakness in my left arm and hand, and extending a little bit into my face. This is a homunculus, as it says on top. This is what these areas, how they're represented in the brain. So there is a little precursor to my stroke. About a week before my stroke, I had transient global amnesia. That's a condition where you have a transient loss of memory for relatively recent events, but also extending back for a few months. I was taken to hospital then, and people looked into that condition. They discovered I had a spray of emboli in my occipital cortex, but the part of the brain that was concerned with memory didn't seem to be affected very much, and I'll come back to that later. And they put me on anticoagulants because they figured it must have started because of a cardiovascular incident. And I was sent back home. And then here's the onset of my stroke. I was sent back home. A friend came by to visit me after I got out of the hospital. We had a nice chat on my deck. And after I saw him out and closed the door, I felt my leg tremble. And I started falling down, and I immediately knew I was having a stroke. I called out to my wife and said, "I think I'm having a stroke." And it was very important that I knew at the time that it was very important that she get an ambulance right away to see if they could do something about the embolus that probably caused it, to break it up so that the effects of the stroke wouldn't be long lasting. She called an ambulance right away and she was told to test for my how I'm smiling, whether I can raise my arms. And she found out that I could raise my right arm, but not my left. I could sort of raise my left leg a little bit. And when I was asked to smile, I could only smile on half my face. I'm telling you all this because I actually remember all of it. There is no loss of speech or consciousness. I was fully oriented and alert and quite concerned that we get to the hospital on time. I remember being in the ambulance going to the hospital. So in some sense, it was a lucky stroke. A colleague of mine, after she met me, a neurologist, Sandra Black, said, "You know, given your profession and everything that I know about you, you had the best stroke possible." Well, thanks a lot. But anyway, I'll keep going on with my story. In the hospital, after they concluded I had an ischemic stroke or infarct, and then after some MRIs, they determined it was caused by a large calcified embolus in a branch of the middle cerebral artery feeding the superior parietal and posterior frontal cortex. because it was a calcified embolus, they couldn't give me these anticoagulants that would be likely to get rid of the embolus, and it was too big and too risky to extract, especially since I was on anticoagulants. They were afraid that in trying to extract that embolus, they may cause a bleed that would make my stroke even worse. So let me tell you about the symptoms, about the impaired and preserved functions that I have. And I'll go through 4 kinds: sensory and motor function, emotion and arousal, social interaction and the sense of self, and cognitive function. I should mention, just remind you, as Narinder said, that I'm a cognitive neuropsychologist and neuroscientist. So I've often assessed and tried to treat people with strokes and studied some of the issues that arose in my own case. I won't focus much on motor function because that's not my area of specialty, but I had left hemiparesis, weakening of the extending to the arm, the hand, leg, and face on the left, and mild hemianesthesia, loss of sensation on the same parts. What I didn't expect to have, because I guess I don't know about that aspect of things very much, I had difficulty swallowing. I had to be put on a kind of almost liquid diet in the beginning, and then slowly progressed to a more solid diet and a mixed, what is it called? I can't remember the word. A diet that had both mixture of liquids and solids. That came at the end. I had trouble maintaining vocal control. You may even see hints of it as I'm talking. And interestingly enough, this is a symptom that I didn't expect and had never read about. I had loss of a sense of ownership of my left hand, not in the sense that I didn't know that it was my left hand, but sometimes if somebody else's hand was seen, I could see it moving, let's say around my keyboard, helping me to type. I thought it was my hand that was doing the moving, and that movement could be extended, that sense of loss of ownership could be extended to certain objects. If, let's say, there was a ruler or a pointer coming into the field, I sometimes mistook it for my own hand. All of that improved with therapy. I should tell you just now, to stop a little bit, the care that I had was tremendous. I would tell people that I felt I was treated like royalty. I don't think anybody else could have gotten better care. And it was a whole team approach, from cardiologist, neurologist, physiatrist, physiotherapist, occupational therapist, and speech therapist. I had the whole works, and everyone helped. I should say here at one of the things that I remember being, just to give you a sense of the loss of ownership of a hand or the loss of movement, my occupational therapist tried to get me to move the fingers of my left hand. I can show you now that I can move them. Not as well as I can move my right hand. I can't do that fancy kind of movement, but it's there. But at the time, in the beginning, they would say something like, move your thumb. To me, it felt like they may as well have said, okay, think hard and move that chair across the room with your mind. I was completely baffled of how separate my will to move, or my attempt to move, was divorced from my ability to move. In the end, after I was in hospital for a week and then sent to rehab for another 6 weeks, and through occupational and physiotherapy, I improved to the point that I couldn't walk in the beginning. I could now walk without any aids. I couldn't move my hand or arm, but now I can do both, though there's a lot of residual weakness in in my left arm and hand, and a lot of not as much agility. And there's still a slight loss of sense of ownership. Occasionally, even when I'm in the car, I don't drive anymore, I should mention that, but it's not because of my motor weakness, especially. But even when I'm in the car and I'm on the passenger side and my wife moves the gear shift, I sometimes think it's my hand moving it rather than hers. So these are things that I didn't see often when I was a cognitive neuropsychologist. I would test the patients, but I often didn't notice these symptoms in them. And these were some of my symptoms. I was despondent, severely depressed, and did not want to live. I called a friend of mine who was a palliative care doctor to find out if there's something that I could do to sort of speed my death, really. And he took me to task and told me a story that was actually quite inspiring. He said he knew a colleague who was a successful surgeon who had the same kind of stroke that I did. Of course, he couldn't continue being a surgeon, but then he continued having a very good life afterwards, became a hospital administrator, and was one of the best administrators in the hospital that the hospital had ever seen. So his life went on, was the message. And I thought my life would go on also. My family, and my wife especially, all were more optimistic than I was, as were the physicians and physiotherapists. They'd seen cases like mine before. I remember coming in and couldn't walk at all, and one of the nurses said, you know, you're not as bad as you think. We have people coming in here who are prone. They can't get off the stretcher or their bed, and they leave here walking normally. In any event, I was still very depressed and couldn't sleep and very agitated. I really don't think I slept for about a week straight. And my healthcare workers noted that and told the physiatrist, and then they got a neuropsychiatrist to look at me. They assessed me, and I was clinically depressed. And they said, you know, you're here to be on rehab, and if you're going to be that depressed, we can't help you very much. So they put me on antidepressant and some very effective sleep aid, trazodone, very low doses of the antidepressant, and that was enough to do it, to get me to feel that I had something to live for and to participate fully in my rehab program. Of course, one of the most important things that, again, I never take into account when I used to see my patients to assess them is to find out just how much support they have from their surroundings. So my wife especially, but my children and friends and colleagues helped me accept my new self and restored my will to live and thrive. That was one of the most important things, and I'll come back to it in a second, about accepting that I was no longer the person I used to be, but I wasn't too bad after all. There's some residual symptoms that remained. I'm a little more irritable than I used to be, and I'm a little more impulsive. But otherwise, my personality was unaffected, or so I'm told. I don't find that it's been affected very much. At the beginning, I was drawn and ashamed to be seen as a disabled person. I tended to focus on my deficits. With encouragement and support from my family, I learned to accept my new self and to reestablish my social contacts and seek them out. I'm a very gregarious person, and I still am. And I think my children especially said, you know, this is what you really like to do. You like to be around people. Don't worry about how you present. You seem pretty normal, except for your motor disabilities. So go out and have friends visit you and so on. And I did. So now I've returned to society, so to speak. I still miss some social activities that depend on agility and mobility, such as dancing. One second, let me see if I can move this away. Outdoor activities, sports, or even playing cards. It's hard for me to hold a deck of cards when you don't have the use of one hand. In fact, that was one of the things that I was, and I continue to be amazed at. I didn't realize just how much I needed my left hand. Happily, though, my right hand is strong and very agile, but it would be great to have two hands. So many activities depend on it. One of them that I didn't mention in the slide is getting dressed. I can now dress myself fully in the morning using only one hand. My occupational therapist taught me how to do that. But what I still find frustrating is how long it all takes. I used to be able to get dressed in around 3 minutes. It now takes me a full half hour to get dressed in the morning. And these are areas that I worked on attention. For example, after my stroke, it's a right hand stroke, I had left neglect, which means that I could not attend to objects or information on my left side. I would sometimes, when I was eating, I would not notice that there would be some food left on the left side of the plate. And I learned very quickly that if I couldn't find something, I had to force myself to look towards the left to see if it was there, and just escaped my notice. I had a poor focus of attention. Initially, I could not even talk to people. It seemed just too hard to focus on what it was that they were saying. I could understand what they were saying, but it was hard to focus on them. And I couldn't multitask anymore. That was one of the things that I was really good at. I could watch TV and read and listen to my wife at the same time. Of course, occasionally she would call me on whether I actually was paying attention to her, because it looked like I wasn't, but I was. I would be able to repeat what she had asked me and answer the questions properly. That ability seemed, I don't think I've regained that. I still can't divide my attention very well. My speech and language were affected in the following way. I had some mild word finding difficulty, some slowed speech, and weaker voice, and some poor articulation and writing errors. Now, those are some of the things that I found very interesting. You'll notice that I made a mistake in typing, or left the N in. When I was writing, one of the things that it may have had to do with my right frontal functions, I would often leave letters off the end of words. Or if I'd have to write my name, so it's the letter M, I would tend to add more sort of continue kind of perseverating on the M a little bit. Most of that has been cleared up. So I still have a mild residual deficit in all domains. And that's one of the reasons that I'm not driving. Because I can't divide my attention well, and I still think I have some mild neglect on the left side. When I walk around the house, I sometimes will brush against furniture on the left side. And really, driving is a multitask. You have to divide your attention, keep your attention on the road, and also at the same time try to make sure that you're doing what you're supposed to be doing and not listen to the radio. Anyway, driving is a problem for someone who has some attentional deficits. So I thought maybe I could try to drive, but I figured it just isn't worth it. If I brush against furniture at home, that's one thing. But if I'm driving and I brush against another car, that's another thing entirely. So what's my current state? I'm in a good frame of mind. I continue working as a neuropsychologist and cognitive neuroscientist. I supervise graduate students, write papers and edit papers. I review papers. I enjoy life and work even while aware of my diminished capacities. And if I ever should forget my diminished capacities, I'm always reminded of them when I get on the bus or on the subway. I never get standing ovations when I speak, but when I get on the bus in my current state, it seems that everybody is fighting, standing up and falling over themselves to be able to give me a seat. So I must present in a way that people realize that I'm impaired, but I don't feel impaired inside as much as other people see me as being impaired. I have less fear of death. I remember at the time thinking, well, if this is what it's like to die, it's not so bad. And then I have a deepened sense of love and appreciation of others. I can't tell you how much my wife put into keeping me optimistic and caring for me, and continues to do so. I think the burden of this stroke has fallen more on her than on me. To summarize, I miss what I lost, but I'm grateful for what I have. If some of you want to see what I looked like before I had my stroke, I'm putting this thing in the on the slide. This is a YouTube of my giving a lecture, I think in 2019 or 2018, quite a while ago, maybe even earlier than that. So you can see what my speech is like. I'm not moving around now because I'm on Zoom, but there I am moving around. So here's some tips. I wanted to put in this Jewish prayer for healing the ill. The prayer is, please send speedily from heaven healing of the soul and of the body to those who are ill. So it's the emphasis on the soul, and that's been a recurring theme in the talks that preceded mine. People refer to their mental health as much as they refer to their bodily health. So here are the 3 top tips for healthcare staff that Narinder asked me to mention. Treat the person along with the illness. And I think my staff, the healthcare staff that dealt with me, managed to do that. They cared about me as much as trying to help me move. I mean, I always felt that I was important to them, not just my symptoms were important to them. Be mindful of the person's mental well-being as well as the person's physical well-being. And this is usually, again, for the healthcare workers, err on the side of optimism rather on the side of grim but imperfect medical knowledge. I mention this because a neurologist told me the story that she had seen somebody with a stroke, not unlike mine, and told that person that she will never be, she is unlikely to ever be able to do some activity that she really enjoyed. And she said 2 years later, that person came back and said, look, I can do all that. You were wrong. You shouldn't have told me that. I was very discouraged because of your prognosis. So unless it's absolutely certain, and I think they're rare that one could be absolutely certain in dealing with people with stroke, they have a range of abilities that they have before the stroke, and each stroke is different from each other one, and the period of recovery lasts a long time. And people know now how to help that recovery process. So the 3 top tips for the patients, 3 top tips plus 1, don't look back, but learn to accept your new self so you can move forward. I think that was the one thing that I managed to do, and not constantly say, look, I can't do this anymore, but look what I can do. And this is the new me, and I wasn't ashamed to reveal myself as an impaired person to other people. Avail yourself of all treatments of physical as well as mental symptoms. One contributes to the other. I think the physiotherapy and occupational therapy that I received would not have been possible if I were in a poor mental state. And they were aware of that and tried to make me feel better. Don't isolate yourself. Embrace human contact as much as before the stroke. I think we're finding out quite a bit in psychology how important social interaction is for all kinds of disorders, including, among others, Alzheimer's disease and certainly in my case for stroke. We're social animals and we should cultivate that part of ourselves as much as we can. And practice diligently to promote recovery and maintain gains. Rehabilitation is tedious, and doing all these exercises is not fun, but they really helped a tremendous amount. And I wasn't told to continue them once I reached a certain plateau, and I regret that because I think I lost some function as a result of not continuing my treatments. Whoops. Okay, so thanks to the Moscovitch family, my wife Jill, my children Ilana and David, and my daughter-in-law and grandchildren Ezra, Eitan, and Mayan, my in-laws, my friends and colleagues who didn't abandon me and came often to visit me, and the healthcare workers, the nurses, the hospital staff, the rehabilitation therapists, and the physicians. They were all wonderful. So here's my family. This is our daughter Ilana, our grandson Eitan, my son David, my wife Jill, our granddaughter Mayan, my daughter-in-law Leora, and one grandson who's at university who wasn't in this picture. Here I am celebrating my an early 79th birthday. My birthday will be on November 20th, but this was a day that we could celebrate because my son's birthday is close to mine. Anyway, I didn't think I would make it to my 79th birthday, frankly, when I had my stroke. But here I am, and thank you for listening. Happy to take questions if you have any.
Okay, Maurice, thank you very much for a lovely talk. We have a few questions here. I'll just go through these and to see how many we can get done in the 10 minutes we've got. Somebody's asked about whether you had any what's called functional electrical stimulation to improve upper limb function. Did that ever happen in your case?
Yes, they tried it. I didn't find it to be very effective, and they would do it. I mean, I can't tell whether it was effective because I improved, but I don't think that helped all that much. And there was a whole program of it. I could enlist in a program of intensive electrical stimulation. And I asked the person who was administering and said, well, what's the evidence that this is going to help? And said, well, on our small little tests that we have, we can find some mild, significant difference. But from our experience and functionality and daily life, she could see nothing happening. So I decided to forego it.
Okay, right. And then did you ever have a formal neuropsychological assessment? And if you did, what's it like being on the other side of the table?
Oh, I didn't talk about that very much, and I meant to. Thank you for the question. I did have, I think they gave me a MOCA at the beginning, not the best neuropsychological assessment, but enough to be able to, I found it mortifying. I was asked to draw a clock. I had asked my patients to do this often, draw a clock and set the time to 10 past 11. I could not do it. I just it's a common symptoms of right hemisphere stroke. I just couldn't do it. I neglected the left side. The numbers were all squeezed in, but not just on the right, but even on the left. I just couldn't figure it out. And I was asked to draw a 3D chair, which also I could do very easily, but couldn't do it at the time. All my deficits were that they found were in these perceptual motor, sensory motor functions. My language, my memory, and so on were just fine. And my memory continues to be great. I still have as good as memory, if not better than most of my colleagues, which is surprising given that I had that transient global amnesia that preceded my stroke. I never went back for a complete formal neuropsychological assessment. I'm sure they'll find deficits. And there is residual neglect. When there's a gystoscopic test where an item is flashed briefly on the left side, and I could detect it if there's nothing else on the screen. But if I have to attend to the middle of the screen, to events that occur in the middle of the screen, I don't even see the stimulus on the left. And there may be some residual extinction, so that if somebody touches my right hand, I don't quite feel it when they touch my left. And there is another symptom that I discovered, a kind of a motor extinction. When I'd work on my stationary bike and I'd pedal with both legs, I could feel my right leg pedaling, but I had to look down to see if my left leg was actually pedaling. I couldn't feel it, but if my right leg wasn't pedaling, I could sense my left leg pedaling.
Okay, very interesting. And then we've asked a question about if you did have cognitive rehab or psychotherapy, was there any particular aspect of that you found particularly useful, either cognitive or psychological rehab?
I didn't have cognitive rehab because, well, two things. I don't know if this counts as cognitive. I had speech therapy because my voice was weak. It may still sound a little weak to you. And I had trouble swallowing. So that was the extent of the rehab, but it wasn't to try to get me to understand speech. It had to do more with my articulation and try to speak as strongly as I could. I didn't have any other cognitive rehab because they didn't think there was anything there to rehabilitate. I had difficulty reading at the beginning because of my attentional deficits. And even following simple TV shows. One show that we liked was called Offspring, that I could follow, and I realized how much cognitive energy is needed to follow even a simple TV show. You have to know what's going on. You have to know what happened before. You have to know what the implications are of what's being said. And I couldn't do that in the beginning, but all that recovered spontaneously. I didn't need to have that. The other part of the question was whether I had any, not just cognitive rehab, but occupation.
Yes, psychotherapy, yeah.
Occupational therapy. Yes, I had a lot of that.
Psychological therapy, no, psychotherapy.
Oh, psychotherapy. Sorry.
Yeah.
Yes, they noticed that I was very depressed, and so they put me on a low dose of sertraline, very mild antidepressant, and I still take it just because
Did they
it's
give you
so low.
but you didn't get any psychological therapy for the low mood as such?
But so I'll get to the psychological therapy. They sent in a social worker as a psychotherapist, and what she did was we just talked. She would listen to me. That was the extent of the psychotherapy, and she taught me some mindfulness techniques that I might be able to use to help me sleep. But all those mindfulness techniques did not work to help me sleep. But the trazodone and some of the melatonin that I took did the trick. But I really enjoyed talking to her. I felt she listened, and I felt valued, but not because of any sort of psychotherapy on its own that did something. Maybe just the talking was sufficient.
Okay, right. And then somebody's asked a question, which I may have to just expand a little bit. Some people have associated the right hemisphere with religiosity or sense of humor or understanding of music. So you think either of those three were affected by your stroke? Religiosity or sense of humor?
Religiosity and sense of humor, I don't think were affected. though my family would prefer that maybe it would have been affected, because I tend to be more observant than anybody else in my family. But that wasn't affected. I think my emotions may be a little blunted. For example, I don't know whether my good humor, in light of all this, is actually a symptom of the disease rather than of my personality. I tend not to be as affected by sad events as I used to be. And my appreciation of music isn't affected, but I can't sing. I don't have the vocal control to be able to sing properly. So I practice that. I used to really love singing. I still sing occasionally, but if there's anybody around me, the message I get is maybe I shouldn't. I can't sing on key. I can't seem to quite find the key that I want.
And maybe just one last question is, somebody has talked about the balancing the encouraging optimism and hope, but not setting too high expectations with patients not achieving that and being disappointed, and maybe that leading to low mood. So how does one balance encouragement but not giving them too high expectations? Any thoughts on that?
I think that no, I have thoughts on it. But I don't know whether I could have any good advice to give. My therapists, my physiotherapists and occupational therapists. By the way, I should just stop and say that I'm lucky because I'm able to continue to speak and think and remember things well. It would be different if I think I had a left hemisphere stroke. But in terms of trying to maintain my optimism, for me, the first thing that happened that I think I managed to do, and I don't know whether this was with everybody's help or just my own, is to accept my new self. And once I was able to do that, I was able to focus on small gains, because having accepted a self that was less than the self that went in before the stroke, I already felt I was okay. And so if any small gain that I had felt terrific. I think I wrote in the paper for your book that learning finally to move my thumb that I mentioned earlier in my talk felt just as rewarding as publishing a paper in a very high-end scientific journal.
Very good.
So
Yes.
small gains really went a long way.
Okay, that's very good. Okay, well, thank you again for a wonderful presentation, and we'll just go on to the next talk now, which is by Ayad Marhoon. We'll be talking about his living with MS, and Ayad Marhoon is a UK-based professional with a background in organizational psychology. He's a project manager at Turati Community Interest Company. He's also involved in the patient carer community at the University of Leeds, where he's working both as a trainer and as a facilitator with students at the university. So I'll hand it over to Ayad to give his presentation.
Amazing, thank you so much. So yeah, hello everyone. Thank you so much for taking the time to listen today, and to be here for the conference. My talk is about living with MS. So just really quickly, so the contents of the presentation. So I'll start with the intro, a little bit about me, a bit about my story, a bit about my new life post diagnosis and post being diagnosed with MS. And then at the end there'll be some tips and some takeaways for healthcare professionals and for other patients in a similar situation. And then finally the Q&A. So yeah, first of all, introduction. So I first wanted to thank Narinder for the opportunity to speak today. I have had the opportunity to give a similar talk to kind of community groups around the UK, to other youth groups, and that's usually from a more motivational perspective. But I think this is the first time I've had the opportunity to speak to kind of academics, clinicians, and it is a real pleasure and a real honor to be able to do it. The way this came about actually in the first place was so similar to Niamh. I published an article in the Psychologist magazine, and Narinder came across this article and asked me to be involved, and I'll be able to touch upon that article afterwards. So about me. So I'm based in Leeds, Leeds in the United Kingdom. Born and raised here, went away for studies in London. So I did my undergraduate degree at UCL in psychology, and then King's College London, I did my master's degree in organizational psychiatry and psychology. Came back to Leeds, and now working at a charity as Narinder mentioned. Working with the charity, but slowly hoping to make a transition to working at the university and kind of ultimately looking at going into teaching. In 2019, I was diagnosed with multiple sclerosis. And so at the time I was 21 years old. And since the age of 24, I have been a wheelchair user, full-time wheelchair user. And so at the moment, like I said, I work for a charity, but also at the same time, I work at the University of Leeds, if and when the opportunity arises. And I work with the medical students on things like communication skills. And I guess you would call me you'd give me the name expert by experience. So someone who has been a patient and kind of has experience to share. So my story. Really quick introduction to MS. So I assume a majority of people will know about MS, but just a quick recap for those who might not be aware. So this is a nerve cell, and around the nerve cell are other cells. These are myelin sheath. The myelin sheath protecting the cells, the nerve cells, is what allows the signals to be passed through the cells properly. The issue is multiple sclerosis as an autoimmune disease. My immune system, for some reason, thinks that the cells protecting the nerve cells are kind of foreign bodies, and so they attack them, they damage them, and this damage means that the signals from my brain to my muscles don't reach properly. So there are 3 types of MS, the most common one being relapsing remitting. So this is around 85% of diagnoses are relapsing remitting. And these can look, the relapses can look very different for everyone. The symptoms in general for MS can look very different for everyone. Relapsing remitting, what tends to happen is you have something called a relapse, and this relapse can come in the form of a loss of sense or a loss of muscle movement, a loss of vision. But what generally tends to be the case, so as you see in this blue line, what generally tends to be the case is you have this relapse and it improves slightly, but not all the way. And the time that it can take to improve can differ greatly from person to person. So kind of it might be a few days, a few weeks, a few months. It just depends. Primary progressive, which is the red line, so that is from the very start, symptoms kind of start and over time they just get better. So you don't experience relapses, but things just kind of progress as time goes by. And the third one, the green line, is secondary progressive. So this starts off as relapsing remitting, but at some point becomes progressive. And usually the time that it goes from relapsing remitting to secondary progressive is between 10 to 25 years. With MS, everything is very vague and kind of averages and any kind of statistics are always very vague because it's very difficult to kind of pin anything down with regards to MS. And at the moment, there isn't necessarily a drug or kind of a treatment for the condition. There are drugs that can be used to help slow down the progression or to kind of reduce the number of relapses that happen. But as of yet, there isn't anything that fixes it or reverses it or remyelinates the nerves. But for each type of MS, there are some drugs that are more effective, some that are less effective. So we'll go into my story. I realize, having seen everyone else's presentations, my slides lack they lack much text. So you have to bear with me because it's more a case of I'll be speaking to you, so I hope you can follow along. So the story of my diagnosis, so pre-2017 to 2019. So pictures of me. Before 2017, I was a very active person. I used to hike a lot. I used to cycle a lot. I used to be a photographer. I used to get around, and I was one of them people that would kind of try to make the most of life. But in late 2017 is when my symptoms first began. So it first began, the first symptom I saw was I was walking home at the time, and for some reason my right leg in particular, felt really heavy. My foot kept kicking the floor, and it was, at the time, I didn't think anything of it. But this persisted for a few months, and I went to see the GP in February of 2018. From the very beginning, I let the GP know, by the way, we have a history of MS in the family. But at this time, I was the least likely demographic to have MS. So I was a young, healthy, active male, which kind of, it was, yeah, unlikely to be MS given my demographic. But so it was kind of suggested to do blood tests. The blood tests were clear. And so they put in a referral to the neurologist. But so this referral initially was put in as urgent, but then after 8 weeks, I got in touch and I was told that I'd be seen within 8 weeks. I got in touch after 8 weeks and they told me I've been taken off urgent referral because it didn't seem like an urgent thing. Again, like I said, my demographic was not one that seemed to have that would be seen to be MS. But eventually I got to see the neurologist, and I was put in for an MRI scan, just of the spine at the time. And the MRI scan showed lesions in the spine, what we call lesions. So this is damage in the spine and appears in the MRI scan as kind of white blotches. Had this of the spine, came back. There was this damage in my spine. I had another MRI scan of the brain. And this was in February 2019. And that showed lesions also in the brain, which kind of, I guess it solidified the diagnosis of MS, seeing the damage in my spine and in my brain. It was seen to be MS. And it was difficult at the time because I was studying in London when I was diagnosed. I received diagnosis when I was a student. Like I said, I was 21 at the time. It was very stressful going between Leeds and London. Leeds is where my care was taking place, and London was where I was studying. So that was a quite big aspect of the story, quite a big difficulty that I had to endure at the time of the diagnosis. And then came the next part of the story, which was from 2019, so the diagnosis, to 2021, which for me was kind of the most frustrating time. So from the very start, when I was diagnosed, I received the diagnosis of relapsing remitting MS. So the one I mentioned the types at the beginning. Relapsing remitting MS, if you get that diagnosis, then you're kind of recommended to take certain drugs. If you get a different diagnosis, you're recommended to take different drugs. So at the time, I started on a particular drug. But very early on, I made it very clear to the doctor that I personally, as a patient experiencing these symptoms, I don't think it's relapsing remitting. I actually think it's progressive. And I felt that I was in a qualified position to kind of make this claim because obviously, number one, I was a patient experiencing all of this. But number two, I spent a lot of time learning about the condition and figuring things out about it to be able to advocate for myself and to be able to challenge if necessary. Unfortunately, 2019, like I said, is when the diagnosis came, when I started on the medication. And then came along COVID towards the end of the year. Lockdown happened. There was no contact with the consultant for over a year. So as I said, I thought it was progressive, and the doctors thought it was relapsing remitting. My condition continued to progress, but then I was able to see the doctor after a year after lockdown. And when I seen him before the lockdown, I went in walking absolutely fine. After a year when I went to see him, I came in using 2 walking sticks. And so it was very evident, obviously, that over the course of a year, there's quite this rapid progression to go from being able to walk to now only being able to use 2 walking sticks. And so at that time, he ordered another MRI scan to be done to see if there was any progression. And the thing is, the scan came back. MRI scans generally are subjective, so it's difficult to kind of make an objective diagnosis from them. But there seemed to be no changes in the scans, so from the perspective of the doctors, there was no kind of activity in the scans, and nothing to suggest that anything is progressing, other than, of course, a clinical progression. And so at that point, like I said, I kind of advocated for myself. I thought it was really important to get a second opinion. And to do so, I had to re-refer myself to another hospital to see whether they could have another look at the scan and to re-diagnose things. And this luckily was where it was picked up. There were actually changes in the scan that had been missed by my original hospital, and it was only when I was re-referred to another hospital that this was picked up. And so that confirmed to the doctors that I should be on a different medication. The medication I'm on hasn't necessarily been effective because there are new lesions, there's new damage in the brain. So at that point, they said, okay, we're going to try a different medication now because the one that you're currently on has been ineffective. And so, yeah, that was it. So I started at that point, 2021, on a new medication. And as far as disease-modifying therapies go, the medication that I'm on at the moment is the most effective. Ocrelizumab, for anybody interested in what the drug is called. But at that point, 2021, when I'd finally been put on this new medication, I was a wheelchair user. And I also, 2021 is when I started studying my master's at London, but things had become too difficult for me. So even the master's, which I studied at London University, even that I did it from home. I did that remotely, just because of the physical difficulties, kind of studying in person. And it was mentioned earlier, so fatigue. At this point, fatigue is very difficult to differentiate from just my physical disability. The first few years of the diagnosis, when I was still up and walking, and even with the walking sticks, it was very evident what was fatigue and what wasn't. There was kind of this strong, overwhelming feeling of tiredness that would kind of overcome you, and it make it very difficult to get up, make it very difficult to walk. But now it's reached a point, obviously, where I can't walk, and it is naturally it's just difficult for me to get up as a wheelchair user. So a lot of people, when they ask me about fatigue, I just tell them it's very difficult at this point to be able to differentiate between fatigue and just my physical limitations. like I said, so with the re-diagnosis, it was kind of confirmed to be progressive MS. So that does mean, unfortunately, over time things get worse. And in theory, the medication I'm on slows that down. But the progression has continued. And so even though it might not be kind of evident to people, my speech has been affected. My speech is very slurred now compared to what it used to be. And also my hands have not completely stopped working, but I'm not able to kind of hold things in my hands. I'm not able to hold a pen. And so yeah, I guess 2021 is where my journey kind of really begins. And it was also at this point that I published the article that I mentioned at the start. So it was when I got the diagnosis of progressive MS, and I could confidently say that I was living with a progressive condition, that I wrote the article. And this article, one of the main elements of that was I was speaking about progression, about how in the NHS it's very goal oriented. So you work towards goals with your therapist, physical therapist, occupational therapist. You set goals and you work towards these goals. But it was, in my case, these goals will be set and it was difficult and even many times impossible to achieve the goals. So instead of it being a useful, helpful, motivating thing, it was instead kind of a disheartening thing. And that was only something I could kind of realize or comprehend, given that I was living with a condition that was progressive and things were progressing. And so rather than, I guess, it being a recovery phase, a lot of people today have spoken about how something might have happened and they recovered and there were lessons to learn from that. From my position, there is no recovery to speak about and there's no lessons to learn from a recovery. And so instead, for me, it was a case of being able to adapt, to be happy, be content with my new life. And so on the screen, you can see these two photos. So before I was diagnosed, I was a very avid blood donor. For some reason, and people, even specialists in MS, are not sure why this is the case. But you're not allowed to donate blood with an MS diagnosis. So the photo on the right is me kind of getting my infusion done, my medication, which is kind of specific to the kind of MS that I have. And so I guess when it comes to my new life, there are 4 things that I've mentioned that I want to talk about. So number 1 is protective factors. And number 2 and 3, tawakkul and sabr. So these are 2 concepts which, these are Arabic words, but they're Islamic concepts which I will explain properly when the slides are coming up. And then the final thing is new opportunities. So kind of things that have come about because of the condition. So protective factors. First one was family. So at the time when I was diagnosed, I had a really supportive family. I'm of Arab heritage, and it's very easy for people in the Arab community to see something like a disability in a very negative way. But I'm lucky in the sense that my parents both came to the UK over 40 years ago, 50 years ago, maybe. So their outlook towards this stuff is very different to the outlook of people back home. Like I said, I have a history of MS in the family, and these are people back home in Iraq in particular. And the outlook towards it is a lot different to our outlook or the outlook of my family. And from the very beginning, my family were invested in kind of the whole journey, and their support was always there, and their outlook was always a positive one. And I think also from their perspective, because both of them had suffered their own adversities, but namely kind of persecution, having to leave Iraq for whatever reason. Their outlook towards adversity was always one which you can learn from. You can kind of grow and develop because of it. Next one was friends. So in that photo is me with my two friends, two housemates at the time. It was very helpful having them as housemates because they could match my kind of outlook and match my energy and match my mindset towards the whole situation. They were very kind of humorous about it, but in the same way that I was. And it's very helpful having them kind of match me on that. And they were also both medical students, so this a lot of people found this quite funny, but they enjoyed using me as a kind of a guinea pig. So in the UK, I'm not sure if they have this elsewhere. They have exams called OSCEs, where it's kind of physical exams where they have to meet people, meet patients, and kind of be examined on their interactions. They used me a lot for this kind of stuff. They did tests on me and they would kind of practice their skills on me. Next thing was studies. So I studied, like I said, I was studying psychology at the time. And so all the staff on my psychology course were trained in psychology in one form or another. I even had one of my lecturers in particular on CBT. She was a clinical psychologist, so I was in very good hands. I had the right people to speak to, and I was always kind of, I guess, very lucky and privileged to have the support I had. And then the final one is religion. And there was something about religion and studies which they didn't necessarily give me the answers to figure out what was going on or why this was happening to me. But a very helpful, very useful thing of both was that they gave me the tools to be able to research and look for the answers, even though they might not have given me the answers as such. But they made it easier for me to kind of look into kind of the concept of positive psychology, and you'll see in the next slide the two concepts I was talking about, but them existing as concepts in the first place. I'll actually just go forward so you see. So tawakkul and sabr, religious concepts, like I said. It's not that they themselves gave me the answers, but it's that they gave me a framework that kind of already existed that I could look into and look for the answers myself and I guess come to terms with my whole situation. So before I talk about them more, I'll explain what they are first of all. So tawakkul from an Islamic perspective is the idea of having full faith in God while still taking action to the best of your ability. So this concept is not necessarily just exclusively Islamic. From a secular perspective, it's kind of the emotional detachment from outcomes and situations that you have no control over. And like I said, this concept, I was aware of it, but I'd never thought about it too much. I never kind of had to think of how it comes to play in my life. And it's a shame I only have half an hour to speak because I could very easily speak about this for a lot longer. But then this takes me on to another concept of reframing and kind of having the right perspective towards things. So the example I always use is I luckily have had the opportunity to travel a lot, and I travel in a wheelchair as a wheelchair user, and I've had a lot of experiences in countries which are not as accessible as here in the UK. So I think the way that I kind of perceive accessibility here in the UK, I compare it against a more difficult life that could be happening elsewhere. Where other people in my situation who might have not experienced the difficulties of other countries only have kind of an ideal example, an ideal perception of what could be and have that to compare against. And there's this really nice quote which I throw in there wherever I can. There's nothing either good or bad, but thinking makes it so. And that was actually said by William Shakespeare. So the idea that you on this topic of reframing, so you have the power, the the freedom to respond to any situation as you wish. And it's up to you whether or not you perceive a situation as good or bad. Objectively, it might seem like a bad thing that I'm now kind of in a wheelchair. I continue to progress. But instead seeing it as a good thing, makes things a lot easier, and I'll be able to talk about new opportunities in the next slide. And the other thing is sabr, we say in Arabic. So sabr is, the translation is patience. But it's a lot more than just patience. So it's about understanding the long term as the short term. So it's very easy to see the span of life as a long-term thing. 60, 70, 80, 90 years, however long someone is to live, it might seem like a long time. But the idea of sabr is we understand even this 90 years, for example, to be a short-term ordeal. And so when you understand things in that way, so this idea of continue having to adapt, I know that over the course of my life, however long it is, I'm going to have to keep adapting to the way that things change. But if I was to look at it from the lens of sabr, this need to adapt is only kind of a short-term thing. It's only going to happen, but I say only, so it's only going to happen for the whole of my life. But in theory, that only is kind of, my whole life is actually quite a short thing. I hope that kind of makes sense. And so, yeah, having sabr, it allows you to kind of have the correct response to a situation. It's very easy, like I said at the start, to be negative about a particular diagnosis, a particular outcome. But having the correct response, a correct outlook to it, is due to having this patience or having this sabr. And new opportunities. So, number one, public speaking. So now, because of the situation, because I'm in a wheelchair, because I have MS, a lot of the time I get the opportunities to speak in public about the situation. For example, today having the opportunity to speak to people. This campaign photo on the left, so with the MS Society, having the opportunity to speak to MPs at Houses of Parliament, to speak in front of thousands on kind of social media and whatnot. Student teaching and training. So as I mentioned at the start, I work at the University of Leeds with medical students. And that wouldn't be the case if I wasn't in the position I'm in, and it's now something that I love doing and I really enjoy doing. Accessibility consult. So this is mostly in a voluntary capacity, but being able to advise community groups around the UK, being able to advise people who are setting ups, for example, or being able to advise people on the accessibility of their building, having that opportunity wasn't a thing before. And the final thing is inclusivity training. So I again have the opportunity to provide this kind of training to a lot of people. Inclusivity is a massive thing. I don't have much time to go on about it, and I realize now that I've almost reached a half an hour. Final thing, discounted tickets. So this is just a throwaway comment, but I, as a wheelchair user, you also get discounted tickets for a lot of things. And so yeah, takeaways and tips. So for patients, know your condition. Being able to know your condition allows you to be able to advocate. Like I said in my story, I was able to advocate for a change in medication, and if I didn't have that knowledge about my condition, I wouldn't have been able to do that. Acceptance, and this has been mentioned throughout today, but acceptance sooner rather than later has such a profound effect on everything, the way that you do everything. And then finally seeing the good in everything. So this is a lot easier said than done, but yeah, I guess this small presentation is not necessarily going to make people see the good in everything, but hopefully it's just a kind of it might spark somebody's interest in kind of exploring the different mindsets and different approaches. And then for healthcare stuff, so this is the tagline that we use a lot at the University of Leeds: person first, patient second. So again, I think this was mentioned, but a lot of patients just want to be seen as a person. A lot of patients want to be heard. A lot of patients just want to be understood, and they want to be appreciated for them as a person, as opposed to just another number. Meet the patient where they are. So it's very easy as a doctor or as any healthcare professional to assume a superiority over a patient who comes in with a particular issue. But it might be the case that they have substantial knowledge about the condition. And I remember sometimes having to receive explanations from doctors as to what MS is, even though I knew what it was. And finally, cultivating a space of safety. So it's very important for patients to be able to have that say, to be able to kind of mention that they disagree, they might have other opinions. A lot of people, because of the lack of safety in a particular space, they will be afraid of speaking up, afraid of giving their opinions, and they just don't have that comfort. They don't feel comfortable sharing what they might be thinking. And so yeah, finally, I just want to thank everybody. I've just gone a few minutes over time, but we can now go for a Q&A, and I'd be honored to receive questions and answer them. So thank you very much.
Okay, so thank you again for that very interesting presentation. We've just got a few questions here. Somebody's asked about doing your studies online. How did that impact on your social life? Did that having to do studies online, did that have any impact on things?
Well, it wasn't necessarily the studies themselves that had an impact on my social life. I think it coincided with me using a wheelchair, and when I'd newly started using the wheelchair, I think I'd made a subconscious effort not to go out and not to be social, because I didn't want to go out in a wheelchair. I didn't want to have to be seen in a wheelchair. So the social aspect of university, yes, obviously because it was online, a lot of that was lost. But I think a lot of my social life, or the loss of social life at the time, came from being in a wheelchair as opposed to not having the opportunity to study in person. It's a lot different now. So since then I've been able to kind of conquer my fears of going out in a wheelchair, and my social life is back to how it was before being in a wheelchair. But yeah, that was the initial difficulties at the start.
And fatigue is something which is often brought up in MS. Is there anything particular that helps you with fatigue?
So as I mentioned, it's very difficult for me now to differentiate my feelings of fatigue to just my feelings of weakness and my inability to walk and to do things. Generally, so when I did feel fatigue, when it was clearer for me what was fatigue and what wasn't, it was a very standard kind of have a good sleep routine, have good eating habits, have good drinking habits. I did spend a lot of time looking into diets and stuff. And I think even during the break, one of the books recommended, like I've read it page to page, and there's a lot on having MS and changing your diet to suit that. So a lot of things kind of is fairly self-explanatory, and it's a bit annoying to not have the answer. But for me in particular, on a personal level, it was a case of kind of, like I said, drinking properly and sleeping properly and eating healthy and just very mundane things, I guess, taking breaks, things like that.
Yeah, so you haven't found that any changes in diet have made much difference. That doesn't make.
So interestingly, no. So I tried for probably over 2 years. I was on a particular diet, seeing whether or not it would help. And this was a diet that was kind of like unanimously in the MS world. It's kind of, this is the diet to try. But as I said at the start, it's very difficult. Like the responses of everyone to everything is very different. Symptoms are different. The way I'm progressing is very different to a lot of people. It's very unlikely for someone to have progressed from running to a wheelchair in the space of 5 years. But it just so happens that that's where I live. The diet hasn't worked for me, and so yeah, as I mentioned in the presentation, it's a case of accepting what my life is, and understanding it as a new life rather than expecting at some point for this recovery arc to begin.
Yeah, okay. And just one last question is about the change in medications that you've had. Somebody's asked about whether that made you feel any different or any change in symptom presentation than when you had the changes in medication.
So this is a very interesting one. So first of all, it's very I prefer not to dwell on what could have been. So a follow-up question to this usually is, if you're on that medication from the start, would it have made a difference? The answer to that is I don't know, and I prefer not thinking about it because I'll never know the answer. In terms of being on the new medication, it's difficult to tell whether there was a change or not, because on the first medication, I went from walking to being in a wheelchair. But when starting this medication, I went from being in a wheelchair to being in a wheelchair. So it's difficult to objectively say what changes have occurred since starting the new medication, because it's difficult to pinpoint any changes being in the wheelchair. I mean, I'm in the wheelchair, and kind of any changes look very similar. Like I'm still in the wheelchair. I don't know if that makes sense, but like visually, it was a lot easier to see my decline going from walking to a wheelchair than seeing any decline on the new medication since being in the wheelchair. So in theory, I think it might have worked in the sense that it's slowed down the progression. But again, like I said, it's difficult to say what changes have occurred whilst being in the wheelchair.
Okay. And just one last question is, somebody's asked you about how should friends act with somebody who's in a wheelchair? Anything that they should know? Any advice to give to people?
So it's a shame that there's only a minute left of our time, but there is a lot to speak on with regards to this. I would say personally, I don't have one preference. From my perspective, I understand that everyone's intentions with how they respond to me in a wheelchair is coming from a good place. Although this is not necessarily the case for others in a wheelchair. Others in a wheelchair may find it very disrespectful if you bring up the wheelchair. Others might find it disrespectful if you don't. And it's kind of like, well, the wheelchair is a part of me. Why is that not being acknowledged? So it's very different. I know that the world we live in, it'd be a lot easier if there was a clear-cut answer to this. But all I can do is give you my perspective, which is I personally am happy with however someone responds to it. And other people will respond differently. And I apologize that I'm not able to give you a clear-cut answer to that question. But it's just the reality of the differences in perspectives.
Okay, well, thank you again for your presentation. And we'll go on to the next talk now, which is, this is going to be a dual talk by Professor Paul Bebbington and his wife, who's Professor Elizabeth Kuipers. So what I'll do is I'll just do separate introductions. Professor Paul Bebbington will speak for about 15 minutes, and then his wife will speak for another 15 minutes. So Paul Bebbington is Emeritus Professor of Social and Community Psychiatry in the UCL Division of Psychiatry. Before his retirement in 2010, he was head of the Department of Mental Health Sciences at UCL. He was also an honorary consultant psychiatrist in the Camden and Islington Foundation Trust. He was for many years chief editor of the journal Social Psychiatry and Psychiatric Epidemiology. In retirement, he has continued to publish his epidemiological research widely in psychiatric journals. He has fairly recently developed Alzheimer's disease, and in 2022 he published a paper in the British Journal of Psychiatry describing its impact on him. So I'll ask him initially to give his presentation, load up his slides, and then his wife will do the second part of the talk.
Well, I have developed Alzheimer's disease, and this is obviously a progressive disease which affects my capacity to think and to remember, particularly to remember. So the first signs of this condition was that I would lose things. I would lose cards, and I would not take my wallet out with me, or I would not have my keys on me, things like that. And it became, I was still at that point doing a certain amount of lecturing, and lectures became increasingly difficult, and I wasn't able to make the points that I wanted to make. So I also had increased difficulty in recalling and ordering events in the recent past. So something which might seem obvious to someone else as being a recent happening was not available to me. And there was also difficulty in focusing attention on some cognitive tasks, and it became much more effortful. One of the things that I originally had was a large degree of geographical awareness. I tended to know where I was, and if I was driving the car, I knew where the car was and the road system of the UK or whatever. And that went, and well-known routes, should have been well-known, were no longer available. I was also more irritable, more labile emotional. I like to think I was reasonably sanguine before I started. I was more easily upset or angered. Next slide, please. Right. So what about the subjective experience of what's going on? So I'm aware that my capacity is changing for the worse, and medium slowly, but medium quickly. I find that memories that I think I have a track of go and aren't available to me. Then they go on unexpectedly, and that causes social problems sometimes. And the further point is that I can try to regain the memories that I've lost. And this is really quite hard to do, and there are tricks that one tries to think of cues that might help. Elizabeth's the best cue. And I can sometimes re-access them, but sometimes not. And that leads to this sort of patchiness in my grasp of circumstances and events. Next slide, please. Also, my ability to think about complex issues and to abstract information has become more difficult. And one of the consequences of this is that I'm reluctant to contact friends and acquaintances. The reason for this is that I may not pick up the tangential cues which maintain ordinary conversation. So my social world is narrow. The telephone is particularly tricky because it's just auditory. Using WhatsApp is easy, particularly if there's more than one person at the other end. I've given up lecturing and reviewing reasonably recently, but I've probably written my last scientific paper. I won't be doing that again. Next slide, please. So, how does this affect me? Well, I'm quieter than I was, slightly less bouncy perhaps. I do try not to let things upset me unnecessarily, although there are things that might upset me. And one of the particular points is that the way I present socially has changed. The interaction with other people is distorted because I'm worried about embarrassment, that I'm worried about not getting something straight. So, and not remembering something I should remember, and it would be embarrassing not to remember. I worry about my effect on close family and friends because they have to accommodate these difficulties. Next slide. So what about my mood? Well, I actually think I feel reasonably cheerful. My capacity for enjoying things is both social and practical. I do a number of active things. So we sing in a choir. We go line dancing, which is an interesting experience. We go to the gym twice a week, or even more sometimes. We have a pleasantly sized garden, which is quite a pleasure to keep on top of. We also have local grandchildren that we constantly taking care of. We also go travelling, so we go hither and thither, really. So recently walking in Crete, and so on and so forth. Next slide. So, how do I try to manage this? Well, first of all, I don't try things that I might not be able to do. This carries the danger that it might be over-restrictive sometimes. There's this trade-off between having a variety of enjoyable experiences and the difficulty I have in keeping hold of the details of those experiences. Things like the circumstances of what happened there, or what happened here, what the dates were. Maintaining my mood requires a degree of emotional and practical dependence on other people. We have to accept that. And it's also difficult to plan because my mental state is slowly changing and the rate of change is unpredictable. Next slide, please. Well, things that help. A daily routine helps, and my wife Elizabeth helps organise that. And it gets noted in the diary and on the whiteboard, and so I can check. If I've forgotten something was going to happen, I'll check on the whiteboard or in the diary, and that helps. And we also discuss each morning what is the right thing to do. And a variety of things that we do include coffee, exercise, keeping friends, and we walk all over Christmas Pass on a daily basis, which is very pleasant. My fancy is that we notice like we're walking arm in arm every day. When we're apart, we share our location on our phones. Technique for doing that, which is very helpful in keeping track of each other. So if Elizabeth's out, I know quite clearly when she'd like to stay again. Then another thing which people may not know about very widely, we didn't know about it until we found out about it, is the sunflower lanyard, which is a sort of little green dog which I wear around my neck. And this is particularly valuable in travelling in airports. And it's interesting that the staff seem to be generally aware of what it is. And basically, it says that I have a hidden disability, and it results in them being very kind and very helpful. So that's very useful. I was offered medication on the episode. I looked it up in the literature, and in any case, I thought that it made no difference to me over a period of time, so I no longer take it. And Elizabeth has joined the Alzheimer's Society and Carers UK. Next slide, please. Okay, so what do we find helpful? What do I find helpful? Well, daily and weekly routines are more or less mandatory for me. I have to know what I'm doing, and sometimes do wrong. To have regular meal time. Interestingly, I don't get hungry in the same way. There are 100 things on today. If there is no meal, I don't feel that I need a meal. We also have good friends and have a good level of social activity, and also physical activity. We walk a lot with it. That provides structure and provides a certain bounce. We have reminders. I mentioned the boards that we write things on, writing diaries, and then not on the phone, but quite a good company. I have started to use a very good local barber fortnightly as a way of keeping myself looking reasonably okay, and my beard is thin, and my beard is cut slightly less regularly. So I quite like that. Next slide, please. Okay. Well, this is possibly keeping the coronavirus against, but questions for healthcare. So remember that people like us can't retain information very easily. Make sure that arrangements are effective and plans. Send reminders. There was actually a reception that was trying to arrange an annual Alzheimer's review with the patient. As I say, couldn't be very wrong. Be prepared to take more time and the patient, because you'll often need to be things. Please be kind. So, is there another slide? No? No, there isn't. Okay. Thank you very much.
So I've just introduced his wife now. His wife, Elizabeth Kuipers, OBE, is Professor Emerita of Clinical Psychology at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. He worked for many years as an honorary consultant clinical psychologist in the South London and Maudsley Foundation Trust and has published extensively. One of her areas of research has been on the impact of caring on carers. He's now Professor Bebbington's carer and followed up his published account with a corresponding personal paper about the demands of caring, and that was also published in the British Journal of Psychiatry. So I'll hand it over to Elizabeth to give her a 15 minutes presentation.
Thank you very much, Narinder, and thank you very much for asking us both to speak about this. It's our late career surge is giving talks about Paul having Alzheimer's and me becoming his carer. I'm starting off by discussing the fact that this quote at the beginning, "Things are different, adjustments are needed," was one of our friends who's also become a carer for his wife and has read both our articles and initially was finding it really difficult. And his latest comment was this thing about adjustments are needed, and that's a very apt and shorthand way of talking about the way things go, which is also what the previous speaker was talking about. This isn't about, a lot of speakers today have talked about recovery, and Alzheimer's is not like that. So it's much more about dealing with things in the moment and trying to manage things as they turn up. So, as has been said, I mean, Paul very bravely, and to combat the stigma, there's something about Alzheimer's in particular that psychiatrists, we know nearly all the psychiatrists in the UK one way and another, and quite a few of them in their older moments have had some sort of dementia. And nobody else has talked about it. So Paul thought he'd stop that and he would write about it and try and combat the fact that despite working in mental health, we both worked there for 45 years or something, people don't like to mention the fact that they might also have a mental health problem in their old age. So bravely wrote about it, and he received the diagnosis nearly 3 years ago now. And the other thing that is also notable from today is that a lot of people have talked about how difficult it was to recognise your own symptoms. Well, Paul was extremely good at noticing his own symptoms very early. From about 2016, he was noticing that things were getting a bit more difficult he went and asked an old age psychiatric colleague who said, yes, you've probably got mild cognitive impairment. And then about 2021, he self-referred himself to the GP and said, I think my memory's not very good. And she said, oh, it's not too bad. He said, no, I think I need to go to the memory clinic, which he then did. And Croydon Memory Clinic was extremely helpful. They have a very detailed assessment. And next slide, please. And also followed it up, because we were being involved with him more recently, there's also followed it up with a brain scan, at which point Paul got the diagnosis. So the initial adaptations, as Paul had discussed, has been kind of the normal, almost normal forgetfulness of being an older adult, of just not remembering where things are and forgetting where you're going when you're going through the doorway and all the rest of it. So that was relatively easily solved by asking Paul to put in what's called a man bag, and it put things in a bag and always keeping there. Because what was happening, he was putting things in different pockets, and then it was impossible to remember which jacket things were in. And things, he talked about the cognitive effects, there's more confusion, not able to abstract in quite the same way. He was having a lot of trouble rewriting a chapter. I don't rewrite chapters anymore. I ask my junior colleagues to do it. Never read books. But well, perhaps I'm going to read this one. But you know, it just needs a lot. It needs a lot of organising of different drafts, and that was becoming unavailable for Paul. So I helped him write a chapter, which had other audits actually. And yes, and teaching on Teams. I mean, the computer is really much more difficult to manage. Finding out where the kind of submit button is and seeing where you need to go on the screen is just much more difficult. Writing this talk is quite difficult for Paul. I mean, it's really much more difficult than people have managed without any problem. And then, not so much now, but getting angry if I try to help, because it's quite difficult to be pointed out that things aren't going very well, or, you know, would you like some help? I couldn't be right, but he wasn't on the right draft, or that perhaps there was another way of doing it. So this has improved, because Paul has understood that these things aren't so easy, and doesn't give talks anymore, apart from this one side this one. And this loss of internal maps. So my colleague, Professor Richard Brown, was very helpful. He did this in sharing allocation on the phone. And it was very helpful if one of us goes AWOL in some way, just to know where somebody else is, as long as the phone is not left in the living room, in which case it's not so helpful. Next slide, please. Now, having done all this research, I've done research in other areas as well, particularly in psychosis. So I knew after all this time that it's not for the faint-hearted to become a carer, and it's not easy to get right. But it's very clear from the research, these next points. Firstly, don't make caring your only role. Don't just become a carer, because that leads to a narrowing of perspective, and it's quite depressive, generally. It's very clear that if you've only got a caring role, it's quite depressing. So I did begin to do this. I sort of cut down my own work commitments. I sort of started saying no to nearly everything. And that wasn't a very good idea. So I'm just trying to now balance things with my academic interests and things. I mean, I have retired now, so it's fine. But just keep that part of my identity going. Secondly, the literature suggests that carers need emotional and practical support, and we have the most wonderful blended family, both here and abroad, and friends and colleagues, and that has been extremely helpful. And the third thing is, if you're a carer, it's very useful to actively try and sort things out. And this is now called coping self-efficacy. I wasn't quite sure what this was when I first came across it. But that you'll find a way to manage, that you'll kind of deal with stuff. So, for instance, the sunflower lanyard at the airport, that's been a complete godsend. Because airports are awful. They're completely anonymous. You move about, you don't know where you're going, you're in a different bit, and it's quite, and Paul goes to the toilet just before we board the plane, and I have been heard to shout Paul extremely loudly over a room full of 200 people. And all the Pauls turn around and wonder what I'm up to. But the lanyard has made a lot of difference. We're now giving assistance loans and we're looked after much better, so I do recommend that. it's got a full label on it saying kidney disability. Obviously, they're not kidney anymore. It is very helpful. So being able to look for help and manage things are key predictors of better outcomes for carers. And finally, the crucial importance of having a good relationship. If you've never liked the person that you're caring for, the problems that these diagnoses bring are not going to improve your relationship. It's very easy to get into cycles of guilt and blame and anger. Whereas if you can continue to see the good bits and hang on to the warmth, that's going to make a lot of difference both to how you feel and how your the person who you're looking after is feeling about it. Exactly. So it's quite a lonely job. It doesn't really remit. It's kind of 24 hours. And the trouble is unpredictable. You think kind of you've got to a level. And I went out to have supper with my brother in town. And I said to Paul, will you be all right? Will you make yourself a sandwich? He said, oh yes, it'll be fine. And I came back at 9 o'clock and he was asleep on the sofa. I said, what did you have for supper? And he said, I don't know. This is Alzheimer's, you can't remember. And I said, well, did you eat anything? I can't remember. And it's that he hasn't got the hunger cue, this is dead. And I hadn't eaten enough to make a sandwich or do something, but I hadn't realised that was his problem. This is habitual and somebody not able to do that for himself. So you need as a carer to be kind to yourself, to realise that things will change and you're not in a position to know that necessarily until it does. The second point is, this is a condition that where things will get worse, not in recovery, but they're trying to manage things. And a lot of people have talked in a lot of detail about how much help they've had from the NHS. And what's interesting about Alzheimer's is that certainly locally there's no commissioning of aftercare. You get the diagnosis, and we had a very helpful dementia nurse come round and talk to us for about an hour. Not putting things off and not moving, this is sort of down for flat, and doing things earlier rather than later. And I had one more phone call from them. But we have not had any other help apart from a yearly review which they nearly organised just before. So I said, well, you don't remember it, you just didn't think I need to be there. So you also need to put plans in place in good time. You need to kind of know how things might go and not just leave it to the last minute. So I contacted a care agency for respite, which we haven't used yet, but we will go and look at local care homes together. There were a remarkable number. When I looked at care homes in this place, there were about 20, I have no idea. That's useful. And I've underlined the wrong bit here. Paul has considerable cognitive reserves. What I meant really was Paul has, you need to emphasise the positives, and that's the point being made by other people talking today. That there are bits that are still going well, and those need to be enjoyed. He looks good, he's very strong, he's always done a lot of weightlifting, so he's very active, so his garden goes well. He was complimented on our walking creep and how fit he was. I asked him today what the capital of Azerbaijan was, and he said Baku immediately. I don't think I knew. No, it is right. It's where COP29 is, but yeah. He still knows all those kind of details, so most people never knew that. And what's been very helpful is to keep him very connected with all the family and the friends and the activities. Next up, please. I now organise everything, absolutely everything. And of course, if I don't remember, it doesn't happen. So that happens sometimes because my memory's not great either. We Paul and I have 3 monthly reviews. We try and talk about how Paul's doing, if there's things I need to change. And as he said, we have these routines. We go out. We've been travelling a lot, particularly with landlord. That has made a difference. We do a lot of visits. We do grandchild care. Go to the gym. Singing in the choir goes really well. Paul really enjoy that, don't you? And it doesn't seem to be a problem doing that. And I think this next point is really important as well, that there are no secrets. Because Paul's being so brave about the diagnosis, everybody we know knows about it. Everybody. So he had an enormous outpouring of support when he wrote his article from colleagues and friends and neighbours and family. And if there's you were talking about your embarrassment is people don't mind about that. They don't mind if it takes a bit longer. They don't mind if they to remind you because they know why. It's not because it's deliberately trying to be difficult about anything. And even the grandchildren, somebody asked me about what do you say to the grandchildren? Well, we say, Granddad has a bit of trouble remembering things. So my 6-year-old grandchild at the time said, well, I've got good memory, I'll go and help. So that's fine, they understand that too. And we have fun, and we love each other, and it goes well.
That presentation. And we have a few questions, and so some people point to sense of smell and sense of taste being affected in Alzheimer's. Have you found that at all?
Answer loudly,
no.
please. Talk loudly, they can't hear.
Yeah, no, I haven't noticed that.
I do all the cooking, and he's very appreciative. So that's nice.
Yes, I can taste good cooking.
It's the hunger cues that seem to have gone.
Yes.
It's interesting.
Okay, right, that's right. And then somebody's asked about Admiral nurses and whether you've used those, and if you have, whether you found them helpful.
Sorry, what was that?
Admiral.
Yeah, there are nurses which I think the Alzheimer's Society has sort of carers, or that I think the Alzheimer's Society has. And have you used any of those? I think they're called Admiral.
I've heard of Admiral nurses. I don't think so. I mean, we had someone round from via the Alzheimer's Society soon after the diagnosis, I said, and she was very helpful, and she home visited. I don't think she was an Admiral nurse, but she was very very clear about sort of managing things earlier rather than later, yes. And trying to be helpful about what we needed to do, and particularly anything that needed sorting out needed to be sorted out now. Don't wait for things to be. Don't wait till it gets too difficult to do it. Try and do it now. But I don't think we've used them.
You're right. Okay. And you mentioned about medication. You tried donepezil, and that didn't seem to be effective. I mean, do you have any views on these new medications which have come out? So one or two are approved in the States, but so far in this country they haven't approved them. These new sets of medications. Do you have any views on those or any other medications in general?
I suppose my position is that I'm slightly suspicious of salesmanship in the absence of enough evidence, really. So I keep an eye on it, but so far I'm biding my time. And yeah.
When we read the papers, the cognitive effects are very trivial compared to the really quite nasty side effects, and I'm not at all surprised that NICE did not approve them. It's too early, and it's all early Alzheimer's, which we're a bit past that stage.
Yes.
Okay, right. And then you mentioned lanyards, using those. I was just wondering whether other things like, say, smartwatches or voice assistants like Alexa, have you used any of those or tried any of those, you think? You find those?
We haven't done that yet. No. Well, the lanyard thing, no. I'm the voice assistant at the moment.
Yes, I thought.
Okay, right. And you haven't had any formal. So have you had any formal neuropsychological assessment or formal cognitive neuropsych therapy or anything? Have you rehab? Have you had any interventions, either assessment or rehab from a neuropsychologist? And is that something you think is superfluous or would be useful?
Well, we haven't had very much, really.
The answer is no. Yes. Just the memory assessment. There was about an hour and a half memory clinic assessment, but there's no follow-up. It's just interesting. There's almost no help. I don't think it will make any difference. I think what we do makes the difference. I think the socialising and the activities, and that's what most of the research says, that you should try and keep your social activities going and your physical activities going. So we do that.
Yes.
But no.
Yeah. Okay, right. So and then the other thing is, some people talk about brain training and cognitive games and stuff like that. Have you tried that, or do you think that's a waste of time, or what do you think? Have any views on what they call brain training or doing these cognitive games?
Gosh, what sort of training, please?
Well, I mean, do you if you
Yes.
you know, do even sort of crossword puzzles or Scrabble or any cognitive sort of games which tax your cognitive capacity? Do you find, have you ever tried them, or you think though you don't think that doing that would be any helpful? Any views on that at all?
We do them, but the research evidence is that it makes you better at Scrabble.
Yes.
And
I'm pretty good at Sudoku. I do it in my head, but it doesn't seem to stop me forgetting things.
It's very specific, yes. So we do them, but it doesn't generalise very well, and it doesn't help your memory, does it? It's interesting.
No.
I think most of the studies say it doesn't generalize very much. And that's the book, Killer Sudoku. Okay, right. Somebody's asked, did you find music and dance helpful? Somebody's asked that question. I think you mentioned that. You do enjoy that.
Yeah. I mean, just enjoy music anyway, but we also do line dancing, which sort of requires Einsteinian capacities as far as I'm concerned. Elizabeth's much better at it.
The good thing about line dancing is that you do it on your own. You do it on your own.
Yes.
You don't have to have a partner do it. You do it in lines, and
Yeah.
if you can't do it, it doesn't actually matter. Which other dancing you have to do together, and you have to learn it, and then you learn a routine and you turn round and round,
Yes.
and that's helpful. But the choir has been helpful. Paul does really well at the choir.
Yes, it's in the line dancing has enabled me to learn a number of racist American country and western songs. But the choir is much
more erudite. Yes.
yes. Mozart and Bach, you know, it's fine. But so I mean, singing in the choir is a learning process which is enjoyable and which probably doesn't do any harm. I'm not sure if it does any good. It probably does some good.
I'm sure it's helpful. Yeah.
But it's very nice. Yes.
And, somebody's asked just one other. Anything you advise to help acceptance of a diagnosis? I mean, some people are a bit reluctant, I suppose, to accept the diagnosis, especially if it's, say, MCI or the early stages, and it might be a bit reluctant. Is there anything do you use on to help people accept that diagnosis? Any advice there?
I don't know. At this end of life, there are a number of things which may happen to you, and so I tend to take a rather fatalistic view, and not cavil too much about it, really.
I mean, if the new medications are going to do anything, then catching it early is going to be helpful. So, being more realistic about the fact that your memory problems may not just be old age, but maybe something more, would actually be the thing to do, which is what Paul did. So, what you can do is suggest that people take it a bit more seriously.
Yeah. And there's been the other thing which has been in the news a lot. There's all these biomarkers and the blood tests, and obviously there's the question of PET amyloid scan, which some people can get and some can't. Do you have any views on potential biomarkers in the next 5-10 years? Do you think that's going to make a huge change to our diagnosis and management of Alzheimer's?
I don't think I have a professional view on how effective and successful that would be, really. I mean, it might. Don't hold your breath necessarily.
No, it's not clear, is it? It's not clear. It'd be very helpful if there was something, but there's always the worry about false positives and just sort of upsetting people unnecessarily. It's quite a long way ahead, I think.
Yeah, it'll be interesting to see how that develops over the next few years. So thank you again for your presentations, and what we'll do then is we'll go on to the last talk shortly. I'll just mention to people that to speakers that in the chat box, quite a few comments have come in for all the speakers from delegates. So feel free to look in your chat box, and you'll see some comments there. So let's go on to the last talk then, which is Jonathan Perera is talking about recovery from a traumatic brain injury. And Jonathan Perera is a consultant sarcoma and joint reconstruction surgeon at the Royal National Orthopaedic Hospital in London.
Hi, everyone. I'm Jonathan Perera, one of the sarcoma consultants and hip and knee consultants at the Royal National Orthopaedic Hospital in Stanmore. I've had a traumatic brain injury, and I'm going to talk to you about that. I'd like to thank Narinder for inviting me to this forum. I've been listening to all the discussions all day, and actually it's quite insightful listening to the stories, because actually the themes in the stories are all slightly different in that some are accidents, your subarachnoid hemorrhages, some are kind of inbuilt into you, the multiple sclerosis, but none of these things that we have all had are asked for. I am in my mid-40s. I'm the father of 3 children now. I had no children when I had my accident. Husband of a pediatrician who is much like the previous speakers, who is my rock. She is the reason I am like this, as well as my parents, who are retired dentists, the brother of a GP, and that's my sister, and my other brother. My brother is an IT service director, so not medical at all. I work in sarcoma and joint reconstruction, so it's a bit of an unusual topic. So it's not really an orthopedic surgeon, and not really a tumor surgeon, but something in between. So we do lots of different things, and we operate all over the body. I've had a lot of experience. I was born and raised in North London. I studied at UCL Medical School, which then joined with the Royal Free whilst I was there, and then it has now separated again. I did my surgical training in the southeast of the UK. I'm the last of the sort of old school, so I was a pre-registration house officer, but then I did some foundation training. I was the last of the basic surgical training, and then did core training. I was caught up in the whole last of the old, first of the new, as in the renaming of now residents, but used to be called junior doctors. I did my specialist orthopedic training in the Royal National Orthopaedic Hospital, which is in North West London in Stanmore. I was the primary researcher in getting it right first time, for those who know what that is. I then did many fellowships to become who I am, because in sarcoma you go all over the body, and it's important to understand different types of surgery: plastic surgery, vascular surgery, general surgery. I actually was in Toronto for a year with the whole family, Mount Sinai, sick kids at the University of Toronto in Canada. And I did a couple of traveling fellowships, and I went to Leiden in the Netherlands with a colleague there who I'm very good friends with, and one of my very good friends in Rizzoli in Italy, who is also a colleague. So I've had a lot of experience in medicine. When it happened was over 10 years ago, but 10 years this year. Saturday the 26th of July at 8:06 was the ambulance call in the morning. The day before, I mean Sunday morning, the day before, I was in hospital working with a colleague who I currently work with, but at the time I was a registrar and they were a consultant, and we were converting this to this, which, as you can probably imagine, wasn't the easiest thing to do. Then went home, had my haircut on the way. I took that photograph, which is my last picture on my phone, bought some food, went home, had a phone call with the on-call registrar because I was on call, and then I went to sleep. Pedro is my car. That's just my name for it. And I were involved in a significant road traffic collision the next day in the morning, 8:06 on the 27th of July, 2014. This tree was involved, and there was another car involved. And believe it or not, that's the only mark left on the tree. And this photo and that picture of me is about 5 years ago. So 5 years after the accident. I went through a process because I'm the young surgeon, so it must be my fault that I had an accident. But it did go through the courts to decide that it was 100% the other guy's fault, which is slightly easier to take, if that makes sense, because my mother-in-law is the one that coined the phrase, and she said it to my wife when I was in hospital. And she said, Jonathan is the best driver I've ever seen. He would drive into a tree to avoid an accident. And that's exactly what happened. And this young man standing next to me on the top of a helicopter pad is John Ferris. He's part of Scottish Air Ambulance. And he and Andrea Riggs, who was his nurse specialist with him at the time, came in a car a little bit like this, not exactly this one, because the helicopter was broken, to fish me out of a car that was upside down as I was having a respiratory arrest before I went into a coma. And everyone talks about their experiences of coma and experiences of what happened. And it, as the slide says, it was a whole lot of nothing. Nothing really, it's just nothing. Like someone pressed pause, there was no static, no flashing lights, no, I saw some pearly gates, I had a discussion with someone, nothing happened, just nothingness, which hasn't changed me, but it gave me a different understanding to what I believed might happen and what I believe happens and why humans believe in religion. That's my first memory. It's not quite the right picture, but I woke up on the floor in the rehab building in Northwick Park Hospital, which is where my rehab was done. I was extremely lucky, partly because of whom I was, whom my colleagues at the time, as in my senior colleagues, my consultant colleagues were, my program director, which I'll talk about in a minute, was, and the number of people I had affected up until that point in my training. Medicine is a very small world, and everyone who knew that something had happened, so much so, years later, even 5 years later, I was at a course in the east of England, so completely miles away from where I did my training in Norfolk, and someone came up to me and asked, are you that trainee? This is when I had finished. I was a consultant that size. Are you that trainee that had that accident? And so, and that's 5 years later, it was somewhat still being talked about because it was so bad. And me being on the floor is me climbing over the side rail of a bed and ending up on the floor and trying to explain to the nurse that my neck was sore and how to put a collar on, because she tried to move my neck around when she put the collar on, and that was a bit embarrassing for them. I then did quite a lot of this. My parents knew and my wife knew that I had an exceptional visuospatial skill, so they bought me a lot of Lego. This is obviously my first attempt at doing it, which was a bit embarrassing compared to what it should like. So obviously I did manage to do it. I did a lot of brain training. I know Narinder has spoken about that, and online games and electronic things. And this is my first. I did eventually get it down to 20 with a lot of training, but my initial score was my brain age is 80, and I was in my mid-30s at that stage. The other thing to talk about is physiology. So because at the time I was extremely physically fit, I didn't have very much body fat, I had quite a lot of muscle mass. In time I was in my coma, I lost 35% of body weight. I was just under 70 kilos and I'm 5'10", but I had a low body fat percentage. And at the lowest point, I was in the low 40s. And that's not a huge amount of weight for someone of my height and size. And all of it was essentially just muscle and bone density. So my recovery was a lot of hard work, physicality, fatigue was horrendous, headaches were horrendous, tinnitus was not very pleasant. The ward TV, as in the rehab ward, was always on a mute because I could not stand the noise and the overstimulation that you would get from having someone talking to you, the TV on. It was quite significant, and I still remember that time. Recovery was, I had a few heroes. That mammoth is one of the first things I made that was actually quite difficult to make. And I've still got it. It actually sits in my office on one of the shelves behind me. This tangle of acceptance, which I think people have talked about all day, and the different, even in the presentations I've watched all day, you can see in different parts of people's story, you can see the bits where they were angry at different doctors even, or people, that how they might be treated, or denied what was happening to them. There was one of the speakers today talked about starvation of himself because that might make his symptoms better to try and help him, and he was essentially in denial, including the subarachnoid hemorrhage, about what was happening to them, because your mind doesn't want to believe that this is happening to me. Recovery is hugely long. 3 months, 6 months, 1 year, 2 years, 5 years. I'm at the 10-year stage, so I'm not even there yet. So essentially, really forever. Acceptance is a really important thing. The man on the left is a consultant anaesthetist who looked after an ITU at St. Mary's. This man is a plastic surgeon who stitched my ear back on. This man is a neurologist with a specialist interest in traumatic brain injury, Professor Sharp, who Narinder knows very well, who I still see more for... he wants to see how I get on because I've had such an amazing recovery. I did a lot of this. Thankfully, at that point in time, museums were free. So I did every single museum in the southeast of the UK more than once. This is one of my favorite ones, the RAF Museum in North London. I did quite a lot of this. Exercise is a huge thing. So one of the things I noticed, and it kind of gave me survivor guilt, about how I was coping, because I was doing so well in the rehab facility compared to everybody else. And most of the people in the rehab facility I was in didn't have a traumatic injury. They had either a hemorrhage or a ischemic injury. And so the traumatic injury, which has been discussed on a national level, seems to respond slightly differently. I can't give you, I'm not a brain person. I don't do any research on it. I listen to my clinicians. I'm a orthopaedic scientist and I can talk to you about that, but I don't do any research on this. Most of my injury was right-sided, but I had essentially diffuse axonal, so I had bilateral sided injury. So it was a big thing. Learning to walk was hard. Hopping was a big thing because on the side that had the most of the weakness, on the left side, and that took some time. And then a lot of these books, essentially growing up again, relearning things that I've already learned. These are my work colleagues. This man on the right is Professor Briggs. He was my training program director. This is my current colleague who I was doing that difficult case with the night before. And this is the man I did my first job back when I came back to work, which was about 8 months after the accident. And he wrote this comment about me, which I thought was apt. Jonathan has been a better trainee whilst recovering from a significant brain injury than many I have seen with no apparent brain lesion. And obviously he's trying to be humorous, which was good. And you can imagine the ARCP panel, the panel of my senior colleagues who are trying to assess me and how I was getting on after the end of my year when I was coming back, and they're reading this. And obviously it's good. It's good that I have managed to be able to get back to that. But again, as it says, it comes with guilt, as in guilt that why me and not others. Has it made me a different doctor? Yes, certainly it has. Doctors are not perfect. No one is perfect. We're not robots. Everyone has personal lives, emotions, things that affect them. They don't read, they're not insightful into what that one thing that they might say to that patient, or that they haven't done for that patient, or that rule, or the reason why they didn't do that, and what that may then do to that poor person who's at the end of that diagnosis or at the end of that section report, for example. I mean, that story is horrendous, and the kind of almost illegal sectioning, which I can't even believe. I can see how it would happen, but it is an horrendous story to even listen to as an observer. I very much understand what it's like to be a patient in hospital. I hated it. I used to call it the blue prison, and I tried many times to escape and plan to escape. It took quite a long time to allow others to look after you, and family and the ones you love are the ones you need. And working as a team with those people, and the way it kind of helped with me is not befriending them. The physios, the OTs, social workers, the neurophysiologists, the psychologists, all of the team I work with had amazing rehab, are the reason why I am here today. And that's also because of my wife and her leading that team and pointing them in the right direction and me in the right direction. Since then, I've had more thank you letters than I've ever had. So in the years before, not that I didn't get thank you letters, but the years before compared to the years after, I've had more thank you letters than I can ever imagine. My injury is extremely hidden. No one would know I had half of my head torn off, and the injury I've had, fractures to my face, all of the other things that I've had. When you look at me, when they see me in clinic, when they see the results, the operations I do, I was operating until just before midnight yesterday, for example, on a huge case which had 10 consultant surgeons in, of which I was one. Successfully went, but you wouldn't expect that. So the injury is extremely hidden. It's difficult to understand. It's very unique to the people that have it. So each person you have to treat completely differently. And then that thing we all have talked about is the acceptance of what's happening to us. I have some acquired issues. I never had a headache essentially in my whole life, I don't think, before. But I have recurrent migraines. And I balance that, I think, with sleep, essentially, and sleep and rest at the appropriate time. So most of it is overload or overuse headaches because I'm doing too much or tasking the injured brain too much. Tinnitus and ballast issues. So tinnitus I just ignore. Sometimes is frustrating. Initially, I used to have to wear certain things to try and help with surrounding noise because that excessive input was too much. And that also works with the balance systems because obviously they're linked. So I do a lot of physical activity and balance training. So actually to do that, to try and help with all of these issues. Certain things I don't do anymore. So I don't ski anymore. I was quite an extreme sports person. I don't do any of that stuff anymore. I live for my family and for the amazing life I do have. Fatigue, I manage extremely closely. And in some respects, I'm quite selfish with my sleep. So I really target the number of hours I sleep. I have power naps when needed. I can sometimes talk too much. That's something I am aware of. So I have insight, I think, into what's going on. And my shorter fuse is essentially managed by mainly just saying nothing. Exercise. I can't tell anyone how important this is. The more physically fit you are, the better for any injury, for anything, but for this type of traumatic brain injury, I can't tell you how helpful it is. A family who loves you and supports you, and essentially you can lean on in those times. Everyone knows who Google is. I think Google invented the duvet day, which is essentially a day not included in your annual leave where you just don't feel quite right and you just need a day at home. And I can't do that because of the job I do. But my duvet days are the weekends, and I get provided with duvet days when needed, essentially by my wife. The acceptance of me. So I was going to put in here the acceptance of the new me, but I think that's completely wrong. And it has not trying to kind of criticize the other speakers by no means. But it is me. I didn't choose this, but this is me. And it's not the new me, it's just me. And I have to my acceptance of what's happened to me is me just thinking this is me. And yes, the old me, as people talk about, was this person, but it was still me. And therefore, just because this is a different me with different things, and I can't run 5K in under 20 minutes like I could before, doesn't make me any difference. I'm still the same person with the same wants. Using my experiences to help my patients, I think that helps a lot. And managing my survivor guilt, and that I do that by giving to charity, by going to events, by supporting people who can't support themselves, and being that patient voice for those patients who can't help themselves. I've got loads of musculoskeletal issues. I'll just deal with that by going to the gym. I'm an orthopedic surgeon, and I've been going to the gym for over 20 years. Aerobic and anaerobic exercise, both, and I can't tell you how important that is for mind and body. And they are forever. I think that's what people miss and what they forget. It's not something it's not like a target thing. Oh, I've got to this level, I need to stop. It's a regular longevity. I need to do this forever. Bit more insights. I think everyone, this is the only real reference I've used, and essentially your ability to be able to plasticize your brain as the time goes on. And obviously I am in this bracket, 40 to 50, but when my injury happened, I was in the 30 to 40, which is close enough to this crossover period. But I think the more effort and the more plasticization you do with time, you can still continue to improve as time goes on, but it requires a lot of hard work and diligence. The gym, the normal aging process happens to everyone. That's just acceptance, gray hairs, you lose muscle. That's what sarcopenia is. I still have a young family. My youngest is only 2. And that can be quite challenging in your 40s, when most people have their children before. And to some extent, I wish I'd had children before when I was younger. It would have made life a lot easier. I can be a bit of a Marmite character because I point out the obvious to people when they haven't seen it. And that's not always liked. And that brings out the green-eyed monsters. Because I have had a good recovery and people see me as different, as a different character, I don't get special treatment, but I think others might think that. So people you work with can be very green-eyed, so be very careful about that. And I'm sure people have seen these kind of pictures. This is just one I thought looked as nice as it did. Most people think life is easy and you start there and you end there, but it's full of challenges. Even if I didn't have this, or even if you didn't have diagnosis of any of the horrible things we've spoken about today, life is challenging. So there's going to be times you're going to have to work really hard. There's also going to be times when it's very easy and you're just cruising downhill. There are no shortcuts, definitely not. I haven't really spoken about this. I don't think many of the other speakers have in huge detail. Some have, but the elephant in the room is my view on life is half, my glass is half full or always full. You could look at the downside of that and the dark side of life, and the dark side is, oh, I'm not the same person I was. I can't do these things as I did before. I could explore. I don't have anything to live. This is just say before I had children. I can't say it didn't enter my mind. I didn't think about it. Suicide in traumatic brain injury is extremely high. And the severity that I had, it's extremely high. And most people with the severity I've had, which is the same severity as Michael Schumacher, don't really get back to much. And I'm extremely lucky. And I don't know why I'm so lucky. I'm just extremely lucky. So one of the things I wanted to talk about is when we were in the rehab block and I still was in my post-traumatic amnesia stage and don't remember much of that, my assessors, my neuro rehab team and the rehab team only aimed quite shallowly low. Let's get him back to maybe a residential home or maybe just a home. And my wife said to them, no, if you aim for here and you get here, then you're going to be happy. If you aim for here and you get here, you'll still be happy, but you'll be that much higher than you were before. So it's the whole aim for the stars and hit the treetops, however you want to call it. But my wife was the one that thought of that, and I can't thank her enough, because I might not be doing the things that I do if it wasn't for her. And just the life lessons that Narinder asked us to talk about. My family support over the years has been exceptional, particularly my wife. I can't thank her enough. You really learn who your friends are, the ones who are there just to kind of there for the show. Oh, I know Jonathan because he's this person. They want to talk about you and the accident, but those ones soon go away, and your friend groups and friend circle gets smaller and smaller. A lot of this stuff just happens as you get older. Most doctors don't know very much about the brain or neurology or anything to do with the brain or how it functions or how we work or how it recovers. And therefore, when you talk to them, they think they do, but they have no idea. And it's difficult to tell them that as another doctor, especially as an orthopedic surgeon. My enforced midlife crisis was in my 30s, so I see life completely differently. And I might be somebody else, but I've completely accepted that this is me and this has happened to me. And the most important thing of life is time. We don't get that back, so use it wisely. My top tips. You only get the time we're given. I'm a cancer surgeon, so I spend a lot of time talking to my patients about giving them time, because sometimes you can't cure them, and giving them time with good function. This is tips for both patients and doctors, Narinder. Sorry, I've combined into a single slide. Be kind. We're only here for a certain time. Be kind. There's no reason to be mean to other people. There's no reason to be that person, the shouty person. Understand why that person's trying to do that to you, if they're trying to do something nasty to you, or why they're doing that. And if they're not your sort of person, just ignore them and completely leave them alone. And then you go your separate ways. Knowledge is power. I spent a long time reading and making my life easier by learning. Recognize when other people are struggling, and that's why they might be, their emotions might be coming out towards you, because they're struggling with something in their life. So you have to be able to have enough emotional maturity to say, well, actually, this person might be struggling because of this, and that's why they might be acting like that. So it's an important thing. Exercise. Everyone has a body type. There's 3 different types. It's a very easy thing to talk about. I'm not going to talk about it today because it's not a discussion about that. But if you exercise for your body type regularly forever, then you'll get the best body and mind you can have. And my final thought is acceptance of what's happened to you is the key, because once you've gone through that loop and you've accepted it, then you're free again, and you're not stuck in the vicious cycle of PTSD or all the other horrible things that can go wrong when you have a big injury or a big problem. I think that's it. Questions and comments?
Right, so thank you very much for your excellent presentation. It was a really inspiring presentation, Jonathan. We've got a few things I bring up. One question is from Martha Turner. Did you have access to rehab in the community after you left Northwick Park, either via the NHS or via litigation? And which parts of that were the most or least helpful in terms of rehab in the community after you left Northwick Park? Did you have,
litigation in the UK is not quite like litigation in America, sadly. I didn't really get very much access. I got access in the community through Drive and I think a favour from the head of the rehab at Northwick Park with one of the other rehab physicians in North London. And then I did get access in the community. And I had to travel like any other patient. And mainly the main reason I got access is because I was getting back to work. And it was to complete, I had full psychometric analysis and psychological reviews. I basically had to do all of those tests to prove that I was me and I could be a doctor again and a surgeon, and all the other tests to make sure that I was safe. And after I've done that, the GMC was involved, obviously getting back to driving and things like that was involved. That was my main rehab, getting back to work. And I think that's why.
Okay, right. And just in terms of the severity of injury, sometimes people use the measures of pre-traumatic amnesia and post-traumatic amnesia, the duration, as an index of severity. And just wondering, in your case, do you have an indication of the duration of pre-traumatic amnesia and post-traumatic amnesia in your case?
So the pre was not very long. I remember up until the day before.
So you don't remember the morning going out in the car or anything? No.
Nothing.
So you've probably got maybe a few hours.
So I've ruminated on this quite a lot. Initially, when I woke up, I thought I was a motorcyclist in a motorcycle accident, and I've never even owned a motorcycle. And I clearly created that in my mind. And there's a building near where we used to live in central London that had an underground car park. And there was a guy who used to live there who had a beautiful motorcycle that I had always looked at. And I've obviously remembered that in my recovery, but I had nothing. I have a feeling of the morning sun on my face, if that makes sense, as a memory before. And then afterwards, it was quite a long time. I think my post-traumatic amnesia was 3 months or nearly 4 months. It was quite a long time.
Yeah. And some people talk about the concept of post-traumatic growth, ways in which people are actually a bit better, or they've found new sort of skills or talents after an injury. Have you come? Does that apply to you? Post-traumatic growth, in some ways, you've got some talents or some ways of looking at things that you didn't have before?
I definitely see things in a different light. Yeah. I explain that by a midlife crisis. If that's how I explain it in my own mind. But essentially, I see the world as a beautiful place, and I enjoy it. That's why I've got this backdrop on my slide rather than a picture of something else. I mean, enjoy it. Enjoy the sun. Enjoy the rain. We're only here plus I'm a cancer surgeon, so that makes a big difference as well. And I appreciate that with my patients.
Yeah. And you mentioned a noise sensitivity as a residual feature. Do you have some light sensitivity as well, or is it just noise sensitivity?
Just noise.
Right. Yeah. And just the last point, which I make just to most of the speakers, really, is I sometimes talk about the 3 Ps: be positive, be patient, and persevere. And that seems to have come across in many of the talks. Would you say that those 3 Ps are quite important?
They are vital. Positivity, that once the acceptance, I still feel this is really important, the acceptance of what's happened to you, and you've gone through that cycle of those 5 things and not ruminated back, or you've not got PTSD about what's happened to you, then those things, the positivity, the perseverance. So I have to do, if I don't exercise regularly, I notice a definite difference in how I'm feeling.
Yeah. Okay, right. So just then, thank you very much. I'll just end by thanking all the speakers again for their wonderful presentations. I'd like to thank the delegates. If you go to the chat box, you'll see the links to the feedback form, which they can fill in. The book's coming out in the next few days, next week sometime. So please buy a copy of the book. All the proceeds are going to charity. And if you go to my website, veteranhs.com, and you want to make a donation to the Amin Abdullah Fund or the Karen Wu Fund, there are some facilities there to do so if you want. So, and a recording of this conference will be on the Institute of Neurology YouTube channel in probably 1 or 2 weeks' time. So again, I'd like to thank all of those who've helped me, Ellis Norton, Amy Grant, and all my colleagues, my co-editors, and my colleagues here who were with me in my place. So again, thank you to all the speakers, and I hope you have a very nice weekend.